Welcome, everybody, joining us today in webinar 243. Since the Hipólito Unanue Agreement started the webinar cycle in May 2020, it's more than 4 years of continuous interlearning. Today, we are pleased to present the webinar Acting with the Heart, a Stop to Cardiovascular Diseases. In 1971, with the creation of the Hipólito Unanue Agreement, the governments of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela joined together with a sense of solidarity and regional integration to make of health a bridge for peace and work for well-being of everybody. Thus, today, the Andean Health Organization Hipólito Unanue Agreement has an important trajectory of unity and constant work with the ministries of health of the 6 Andean countries in order to realize the right to health in the midst of the technological globalization. The COVID-19 pandemic reaffirmed the relevance of the health sector for a life with well-being. That's why today it is a priority to keep health at the center of policies and the social awareness, to unite for the common good in order to advance in a society that cares for life. Health is the bridge to integration and peace. For this reason, in the Strategic Plan for Integration in Health 2023-2030 of Horace Conhu, we argue to ensure the full realization of the right to health with social and environmental justice, it is key to work intensively in the strengthening of the health systems, emphasizing primary healthcare. Reflections like these and diverse information of the activities that we carry out in Horas Conhu can be found in the newsletter Notisalud Andinas, a monthly edition that we invite you to read and that it's available in the website of Horas Conhu and in the knowledge showcase of the Andean integration. We would like to invite you to leave your name, your organization, and country in the comments box of the Facebook Live chat or the YouTube Live chat. In that same space, you can leave your questions or send them through via the email webinar@gmail.com. To access the certificate of attendance in any of the chats, Facebook Live or YouTube Live, you will find a fixed link where you will have to fill out a short survey and leave your data. Please verify that your email address is spelled correctly. Send the certificate, which will be sent to you during the next week, during the following week. In this webinar, we will follow the usual dynamics. We will start with the institutional greeting, followed by the keynote speeches, and then we will have a dialogue based on the questions asked by the participants in the different platforms. To start this important session, I will give the floor to Dr. Marisela Executive Secretary of the Andean Health Organization, who will give the welcome words and institutional greeting. Dr. Marisela, please, you have the floor. Thank you very much. Good afternoon, good evening, everybody, wherever you are. Welcome to this new webinar organized by the Andean Health Organization and Hipólito Unanue Agreement, which is part of the virtual events that we organized as part of the actions that we required to promote distance training of the human resources and for the continuous interlearning actions that we conduct as a priority. In this occasion, the Andean Health Organization has prepared this webinar titled Acting with the Heart, a Stop to Cardiovascular Diseases, within the framework of the celebration of the World Heart Day, which is celebrated every September 29th. And we do this since in 2000, the World Federation of the Heart, with the support of the World Health Organization and the United Nations Organization for Education, Science, and Culture, UNESCO, designated this day as a strategy to raise awareness and to share knowledge of the cardiovascular diseases. Since the year we started worldwide a raising awareness on the heart conditions and their risk factors, because these are the diseases with the highest index of mortality and more that are affect more the countries of low and medium income. This year, with the motto "Use Heart for Action,"
pretende hacer un llamamiento
we
global a
pretend to
considerar
make a
usar
global call
cómo usar nuestro corazón
to
para que
consider how
todos
to use
los
our hearts
ciudadanos,
so that
las
everybody
autoridades,
from our own places,
personal de
whether
salud,
we are authorities,
grupos
health
de
staff,
pacientes, sociedad
patient
civil
groups, civil
y público en
society,
general,
and public in
actúen
general,
decididamente
act
sobre los factores
decisively on
desencadenantes
the
de las enfermedades
factors that trigger
cardiovasculares
cardiovascular
en búsqueda de
diseases,
las estrategias
seeking
para
for
disminuir su alta
strategies to
prevalencia.
decrease their very high
Estamos
prevalence.
hablando del
We are
asesino más
talking
grande del
about
mundo,
the largest
dado que
killer in the
mata
world
más de 20
because it
millones de
kills more than
personas en el
20
mundo
people,
cada
20
año.
million people in the world every
Por
year.
eso
That's
es
why
fundamental
it is
que
critical
conozcamos
that
nuestro
we
nivel
get
de
to know
riesgo
our level of
cardiovascular
cardiovascular
antes de que
risk
aparezcan
before
manifestaciones clínicas
there are
y
clinical
así
manifestations
poder
showing up.
iniciar
And in this
estrategias
way,
de
we would be
prevención.
able to start prevention strategies.
Pero ¿qué es un factor de
But
riesgo
what is a
cardiovascular?
cardiovascular risk
Es una
factor?
característica
Well, it
biológica
is a
o
biological
un hábito
characteristic, or it is
o
a
un estilo de vida
habit or a
que aumenta
lifestyle
la probabilidad
that increases
de
the
padecer
probability or the
o morir
likelihood of
a causa de una enfermedad
suffering
cardiovascular
a
en aquellos
cardiovascular disease
individuos que lo
or die
presentan.
out of this disease
Y
in those
tenemos factores de riesgo
persons that
no
have it.
identificables,
And we have
como el
uh,
sexo,
risk
la
factors
edad,
that are
los antecedentes
non-identifiable, like sex,
familiares, la
age,
raza
family, um,
y factores de riesgo
background,
modificables
race, and some
como
other
la
that are
hipertensión
modifiable,
arterial,
such as
la
high
diabetes, la
blood
obesidad,
pressure,
el
diabetes,
colesterol malo
obesity,
elevado
the bad
en sangre,
cholesterol when it is
la
elevated
falta
in
de
blood,
actividad física,
the lack of
el
physical
tabaquismo y el
activity,
estrés.
smoking, stress.
Los cambios en el estilo de vida que se están
Changes in
dando
the
en nuestras
lifestyle that are
sociedades,
happening in our
como la adopción de
society,
estilos
like the
poco
adoption
saludables
of
y
unhealthy
el aumento
diets,
del estrés,
the increasing
sedentarismo,
stress,
influyen en el
sedentarism,
desarrollo de
they all
enfermedades
have an
cardiovasculares y
influence in
su
the development
prevalencia
of
va a aumentar.
cardiovascular diseases, and their prevalence is
Pero
increasing.
hay esperanza.
But there is
El
still hope.
80% de las muertes
There is still hope
prematuras
because
por
80% of
enfermedades
the early
cardiovasculares
deaths
se pueden
out of
prevenir
cardiovascular diseases can be
al
prevented
realizar pequeños cambios en
by
nuestro estilo de
making
vida,
small changes in our lifestyles,
manteniendo una alimentación
maintaining
saludable
a
basada en
healthy
frutas y verduras
feeding
frescas
based in fruit,
y
fresh
dejando a un lado los
vegetables,
productos
and leaving
procesados,
aside processed
las
products,
grasas y los azúcares,
fats, and sugars,
manteniendo un peso adecuado,
maintaining an adequate weight,
disminuyendo el consumo de sal,
decreasing the consumption of
realizando
salt,
actividad física,
conducting physical
evitando el
activity,
consumo de alcohol y
preventing
tabaco,
the consumption of
realizando
alcohol
controles
and
periódicos de la presión
smoking,
arterial,
having
glucosa en
periodical
sangre,
test of
perfil
our
lipídico
blood pressure,
y
lipidic
evitando el
profile,
estrés,
uh,
asegurando un
glucose
buen
in blood, or
descanso y horas de
preventing
sueño
stress, guaranteing
adecuadas.
good rest and adequate
Cuidar tu
sleeping
corazón es
hours. Taking
responsabilidad de
care of your
todos.
heart is responsibility of
Reitero el
everybody.
agradecimiento a
I
todos los
reiterate
hermanos
my
panelistas que nos
appreciation to
acompañan
our
en esta
two very
ocasión
distinguished panelists that have
y a
joined
todos
us
nuestros
in
participantes
this session,
de los
and to all the
diferentes
participants
países
from the different
latinoamericanos y de
countries,
otros
Latin American
continentes que
countries, and
semana a
some other
semana
continents as well, that
nos
week after
acompañan
week
en esta
join us
transmisión.
in these activities.
Bienvenidos, bienvenidas
Welcome,
todos. Gracias.
welcome everybody. Thank you. Thank you very much, Dr. Malki, for your words. After the greetings of our Deputy Secretariat, I introduce myself. My name is Magda Hinojosa. I am a physician and coordinator of a life course in the Allian Health Organization, and today I will be very pleased to be in charge of the moderation of this webinar. Next, to present the topic, ischemic heart disease presentation and management at the first level of care, I would like to introduce Dr. Edith Chavez Guapaya, who is a medical doctor, graduated from the Federico Villarroel University from Peru, specialist in cardiology from that same university, has a master's degree in human medicine by the Peruvian University Cayetano Heredia with a specialty in nuclear cardiology performed at the Cosme Argerich Hospital in Buenos Aires, Argentina. She did an internship in heart angioresonance at the Hospital das Clínicas from the National Institute of the Heart in Sao Paulo, Brazil. Besides having a fellowship in cardiac angiotomography and imaging in cardiology granted by the Cedar Sinai Cardiovascular Medical Group from LA, the United States. She has a master's degree in cardioresonance from the University of Navarra, and she's the former medical director of the Heart Institute Association of the San Pablo Hospital, member of the Peruvian Society of Cardiology, the American College of Cardiology, the American Society of Nuclear Cardiology from the United States, and the American Society of Tomography. The Peruvian Society of Cardiology awarded the National Cardiology Prize for the best young cardiologist scientific work. She has also a long list of research papers. Dr. Chavez, you have the floor. Welcome. Thank you very much, Dr. Hinojosa. Thank you for the presentation. And I would like to also thank the Andean Health Organization for this honor, allowing me to address you and all the attendees to this session to share with you some knowledge. Very especially and very particularly, I would like to thank Dr. Carmen Calle and the authorities of this organization that I see work extensively for the well-being of the health of our population in the different countries. I'm going to present ischemic heart disease presentation and management in the first level of care. I would like to mention that the first level of care with regards to ischemic heart disease is and should be very much linked to what follows after the first level of care. There cannot be a first level of care in ischemic heart disease without having the same at the following levels or the next levels. Everything should be connected in order to be able to work in for the end of saving a life. I cannot pass my slides. I don't know if someone can help me. I don't know, but I cannot pass my slides. Now I can do it. Okay. According to the World Health Organization, the incidence, sorry, there is error. The incidence is the mortality 30%, the incidence 1.8 for each 100,000 inhabitants. And for 2030, it is estimated that it will increase to 36%. That means that out of 7 men, 1 will die due to coronary disease, and out of each 6 women, 1 will have coronary disease. The ischemic heart disease is the most frequent cause of death all over the world, referring, if we talk about diseases, and it represents in men 44% of incidence and in women 38%. How does coronary disease start? It starts with a arteriosclerosis process. This process affects the endothelium. Here in the figure, you can see the endothelium, how it gets deteriorated since we are born with a healthy artery until it deteriorates because of an inflammatory process that happens in the internal part or the internal lining of the artery that then deposits under the endothelium, the LDL, cholesterol, platelets, fat, the lipoproteins, and it will stringent the vascular area up to a moment in which there is a thrombus because of inflammation, and the artery doesn't flow any longer. There are also pathologies with coronary arteries without obstruction, but the most frequent thing is that the artery will obstruct, sometimes very early at the life, especially when the patient has the risk factors that Dr. Hinojosa has already mentioned. The more factors a patient have, the earlier this process will start, coronary arteriosclerosis, and there will be a plate that will form there that might be a vulnerable plate, the most inflamed it is. This is a coronary tree, excluding the image of the heart with healthy coronary arteries. This is at the CT scan, and this is the vascular endothelium, the internal lining of this artery. This is a vascular model, the muscle lining and the external protective lining. These there are, here you have healthy cells, no inflammation. Here you have, on the other hand, an artery where there is already an arteriosclerosis process. There is an inflammatory process here already, and on the vulnerable plate that is here to the right, where there is a fibrous layer, lipids, there is a thrombus that occludes the artery at the end, but this acute occlusion process, which determines an acute condition that leads to a danger of death for the patient, started many, many years ago. Which are these risk factors? Well, we have been very precise in detailing that the risk factors are high blood pressure, elevated cholesterol, especially the LDL cholesterol, the HDL very low, the high density protein of the cholesterol very low, mellitus, diabetes mellitus, obesity, smoking, the increase of the uric acid, the sedentarism and physical inactivity, which nowadays with the remote controls, the cell phones, etc., computers, etc., sedentarism is getting to very high levels. If that goes hand in hand with obesity, stress, and other factors that are many more. Among them, we consider the genetic factor. The more factors you have, it is not that the risk adds up, it gets potentiated, but most of these factors, as you can see, are factors that can be prevented, that can be treated from very early ages in order to be able to modify the future history. If we are focused on doing primary prevention when the patient is young, showing them to exercise, to control their cholesterol, not to be obese, not to smoke, and all of that, well, with all that, we will make this disease to decrease its incidence in the future. In the future of every person, actually, and little by little, step by step, we will be able to decrease the mortality of this disease that affects the world so much. How the myocardial acute infarct is described worldwide. This is defined as a necrosis of the cardiac cells in the context of acute myocardial ischemia. So this is for the infarct that happens because of an atherothrombotic event. There are other causes as well, which are not the topic of the presentation today, but that's the definition. The classic symptom is an anginous type pain, which is characterized for being a usually oppressive pain related to the upper limbs or to the back or to the lower maxillar. But there are atypical symptoms as well, like an epigastric pain, pain only in the lower maxillar as well, or the painful left upper limb. Especially, we need to be and pay a lot of attention to the type of atypical pain in women that do not have the classic precordial oppressive pain. There's also what we call the andinous equivalents, especially in diabetic patients, for example, that might not have a pain in the chest, but they have fatigue. They have this unexplainable fatigue, being dyspnea and andinous equivalent. That is why we need to make a good clinical evaluation. We need to have a good interview with the patient, a good analysis of the pain, of the symptomatology of the patient. And after that, we need to pay attention to the electrocardiogram. If we find a full blocking of the cardiac free or an atypical pain, we might think that there might be an infarct and that the risk is very high.
Entre el síntoma y la asistencia
Between
médica,
the symptom
lo
and the
más
medical care, the
importante es la
most
evaluación
important thing
precoz.
is
Y
the
no solo
early
precoz,
assessment, and not only
sino
early
que nos
assessment,
lleve
but
a tomar
actually an
decisiones
assessment that should
rápidas,
lead us to make
desde el
rapid
inicio de los
decisions from the
síntomas hasta
beginning of
la
the
acción
symptoms
del
until the
profesional de la
action of
salud.
the health
Es
professional.
muy
It is
importante porque el
very
tiempo
important
es
because
vida.
time is life.
Esa
That
terminología se ha acuñado para
terminology
poder
has been coined in order
expresar
to be
que
able to
cuanto más
express
rápido
that
actuemos
the
una vez que nosotros
faster we
tengamos
act
contacto con el
once we have
paciente,
contact with the patient,
más células salvaremos,
the more
mejor
cells we
miocardio
will save,
conseguiremos,
a better
más células
myocardium
sanas
we will
podemos
get,
rescatar del
more
infarto agudo y
healthy
evitaremos
cells we
todas las
will be able to
consecuencias que
rescue, and
vieron
we
en
will
el
prevent
futuro de un paciente que ha
all
tenido
the consequences
un infarto
that
agudo del miocardio.
a patient that has
Entre los
had an
síntomas
acute
y la
myocardial
asistencia médica,
infarct
lo más importante es
has
la
in the
evaluación
future.
precoz.
The most important
Por
part,
eso
therefore,
decimos,
is the early assessment. That's
evaluemos
why we say
tiempo
let's
puerta,
evaluate
aguja.
the
Ya
time
vamos a
um,
entender luego qué
door
cosa es
nail,
puerta
and we
aguja
will
y qué
then
es puerta
understand what does
balón.
this mean and what
Porque
is
hoy
a
por hoy
port
el
balloon,
tratamiento
because
debe
nowadays
ser
at this point
inmediato y
treatment
donde
should be
hay
immediate, and
asistencia
if there
de alta
is
tecnología,
high technology
debemos
assistance with high
entrar con un
technology,
catéter para
we
abrir
need
la
to
arteria.
get
A
it
eso se refiere puerta balón.
with a catheter to open
Una
the
vez que nosotros
artery.
evaluamos al paciente con dolor en
That's
el
door
pecho
balloon. Once we
y
evaluate a
pensamos que
patient
se
with
trata de un
pain in the
problema
chest and
cardíaco,
we think that
podemos
it is
tener
a heart
diferentes
problem, we
escenarios
might have
clínicos.
different
Podemos
clinical
estar ante una
scenarios.
angina
We might be
inestable,
before
un
an
infarto
unstable
agudo del
angina
miocardio, ST muy
and
elevado,
a
o un
non-elevated ST
infarto agudo del
myocardial
miocardio,
acute
ST
infarct
elevado.
or an
En angina
ST
inestable
elevated
podemos tomar
myocardial acute
acciones, podemos
infarct.
hacer
In
exámenes
unstable angina, we can
diagnósticos para
make
asegurar
diagnosis, we can do the
los
exams,
pasos
we
a seguir.
can do something to
Igualmente, el
guarantee
infarto
what
agudo del
or to
miocardio
decide what
ST muy
steps to follow.
elevado nos da un poquito más de tiempo,
Likewise, in
pero
the
necesitamos
non-elevated ST
la
myocardial
acción
infarction,
tiene
the
que
same,
ser
but in the
inmediata.
non-elevated
Puede
ST
haber una
infarct,
presentación
we need
clínica,
to have
como
immediate
digo,
action.
o
There might be
asintomática
a
inclusive.
clinical
Y ahí
presentation that is
nosotros tenemos
oligo
que
or
ver
asymptomatic. And there
los
we need to
factores de
see what
riesgo,
are the
las
risk factors,
circunstancias
what
del
are the
paciente.
circumstances of the
Tenemos
patient.
que evaluar
We need to
el dolor
evaluate
oral
the pain,
psicoresistente y estar
the
atentos a que no
pre-existent chest
estemos
pain,
ante un
and
shock cardiogénico, ante una
be
insuficiencia cardíaca e
attentive that we are
inclusive en
not
un paro
facing
cardíaco.
a
Un
cardiogenic
infarto
shock
agudo de
or
miocardio puede debutar
heart
en un
arrest.
paro cardíaco. Eso
Um,
es algo
it
que no
might start
debemos de
with a
olvidar,
cardiac arrest.
porque
This
en los
is something
primeros
that we
minutos
must
después
not
del
forget because the
síndrome
first
coronario
minutes
agudo
of having
son
the acute coronary
más
syndrome
frecuentes las
are
arritmias reales. Por eso,
it's more
la
frequent to see
Asociación
serious
Europea de
arrhythmias. That's why
Cardiología
the
emite cada año las
European
guías de
Society of
trabajo
Cardiology issues
y en
guidelines
esas
for
guías
the
deben ser
management
ustedes
every year. And in
atentos.
these guidelines, you can see
Está
here,
muy importante el
we see
escenario clínico y
the
luego de
clinical
eso
scenario. And
está
after that, we
saber
have
si el electrocardiograma
to
es
know
normal
whether
o
the
anormal. Hoy por
ECG is
hoy, con
normal
toda
or
la
abnormal.
tecnología que
Nowadays, with
tenemos a
all the
nuestra
technology that
disposición,
we have
nosotros
available,
no deberíamos
we should
pensar
not
que si el
think that if
electrocardiograma es
the
tomado en un lugar
ECG is
lejano a la
taken
capital,
in
no
a
pueda ser
place far
transmitido
away
por
from the
WhatsApp o por
capital cannot
cualquier
be
otro medio
transmitted by
a
WhatsApp
un
or any
lugar
other
donde
means
sí nos puedan
to a
dar
place where they can
rápidamente
give
una
us or send us
interpretación rápida
rapidly
del
a rapid
electrocardiograma.
interpretation of the
¿En qué contexto nos
electrocardiogram.
estamos moviendo
In
y si
what
el paciente
context
se
are we
encuentra
moving,
estable?
and if the
¿Cuál es
patient
la
is stable,
circunstancia
what is
diagnóstica que
the
tenemos? Y
diagnosis
poder iniciar
circumstance that we
inmediatamente
have,
las
and to be able
medidas
to start
terapéuticas.
immediately the
Aún en el
therapeutical
primer
measures.
nivel de
Even
atención
in the
tenemos que
first
estar
level of care,
capacitados
we need to
para
be
poder
trained
ofrecer
to be
un
able to
tratamiento
offer
agregar, asociar un
anti-aggregant
medicamento
treatment
anticoagulante.
and
¿Por qué no
associate an
iniciar,
anticoagulant treatment.
si es
And one way
posible, si yo
to
estoy
start, if
lejos de un
possible, if I
hospital
am far away
donde
from a
tenga todo el
hospital where
equipamiento
I
para
had
hacer
all the equipment
cateterización,
to do a
iniciar con la
catheterism, I
trombolisis?
might start a
Inclusive podemos
thrombolysis.
iniciar la
We can even
trombolisis
start the
en la
thrombolysis
ambulancia.
in the ambulance.
Existen
there are well, there are
diagnóstico que
ambulances in
veo
Lima, in the city of Lima, where you can have cardiovascular
Entonces, le
monitoring,
prestamos atención
cardiodefibrillator,
a
etc. So we pay
¿Sabe qué
attention to
cardiograma
the
normal?
ECG. It is a
Es
normal
una
ECG.
depresión del
It
segmento
is
ST,
the
como ustedes
pressure
ven
of
aquí,
the
que puede ser en una o más
ST segment, which
interpretación,
might
o
be in one
estoy
or
ante
more
un
uh,
electrocardiograma con una
areas,
elevación de
or
50
I am
centímetros,
having an elevation
más
of
de 2
the ST
milímetros
segment
si
of
es en
more
dos
than 2
derivaciones
millimeters. If it
continuas,
is in two
estoy con un
continuous
infarto
areas,
ST
I'm
elevado.
having an
En
elevated
ST
ST
elevado,
infarct. And in
tengo
that
que dar
case, I have
rápidamente
to
la
give
asistencia a este
rapidly
paciente.
assistance to this patient
Rápidamente, antes de los 10
rapidly.
minutos debería iniciar
Before
un
10 minutes, I
tratamiento
should
efectivo.
start
Si
an
estoy ante
effective
una
treatment.
arritmia
If
maligna,
I have a
tengo que
malignant
activar
arrhythmia, I have to
un
activate
código de paro
a
cardíaco para poder
code of
asistir al
heart
paciente y
arrest to
rescatarlo
assist the
del paro
patient
y
and
luego
rescue
tomar
the
una serie
patient
de
from
medidas. Si
the rest,
inmediatamente
and then
estoy
take the following measures.
ofreciéndole al
Immediately,
paciente
I will
muestras
be
de
offering
sangre
the
para la
patient
solicitud de
blood
troponina. En Perú nosotros
samples
respondemos
for
a la
troponin.
troponina.
In
Por ejemplo,
Peru, we
aquí
have
tenemos un
troponin. For example,
electrocardiograma
here you
de
have
un
an
infarto agudo del
ECG with
miocardio.
an
Fíjense,
acute
ustedes ven que el
myocardial
ST,
infarction. You can see
segmento ST
the
elevado,
ST segment,
la
which is pretty
apreciación
elevated,
debe
and
ser
the um,
muy rápida.
appreciation
Disculpen
should
que
be very,
insista
very
con
rapid.
este tema,
Sorry
pero
that I
tenemos que
insist with
hacer
this, but
énfasis
we
en
have
lo que
to
es el
make
tiempo
emphasis. We have
de
to give emphasis
diagnóstico
to
y
time, the
tiempo de inicio
diagnostic
de
time,
tratamiento.
and the time to the
En
diet, to
estos
the beginning,
pacientes
to the
con un
starting of the
ST
treatment. In this
elevado, que los
patient with
podemos recibir en
elevated
la
ST that
posta,
we can receive
los
in a
podemos recibir
medical center, in a
en
medical
cualquier
post,
lugar.
in any
Acuérdense
place.
que
Remember,
tristemente hemos
please, that
despertado hace
sadly we
poco
have seen
un
little
periodista
ago
muy querido
a
en
journalist,
la
very beloved
televisión. Hasta le
journalist,
pasaron por un
very
video
beloved in
el
TV.
paciente se
They
puso
even
mal en
show
pleno
a video
partido de
that the
fútbol,
patient
se
was playing
detuvo, se
a soccer
sentó
game. He
en una
felt
banca
bad.
al
He
costado
stopped. He sat on a
de la
bench
cancha,
next to the
se
field.
fue a los servicios
He
higiénicos,
went to the
tomó una
toilet,
ducha,
take
salió,
a
se
shower,
fue
took
y
a
tomó un
shower,
taxi
then
y
got from
llegó
there
a
and
una
took a
institución de
taxi and
salud
get to a health
y no
facility,
pudieron
and they
salvarle la
couldn't
vida.
save
Hemos
his
visto
life.
también
We have also
futbolistas
seen
que han hecho muertes
soccer
súbitas,
players that have had
quizás por
sudden
otras
deaths,
razones, de
maybe
repente
for
no
other
por
reasons,
infarto,
maybe not
pero una
because of an
evaluación clínica
infarct, but a
inmediata nos
clinical,
puede
immediate
ayudar a
clinical
salvar la
assessment
vida.
might help us
La
to save
troponina
some
es
lives.
un
Troponin,
biomarcador que
which is a
obtenemos de la sangre
biomarker
del
that we obtain
paciente,
from the
nos
blood of the
puede dar
patient,
una idea
um, can
de
give us an
cuáles son las
idea of which
concentraciones
are the
iniciales.
initial
Puede no darnos
concentrations. It
diagnóstico, el
might not give
diagnóstico es
us the
clínico.
diagnosis. The
El
diagnostic is
diagnóstico es por
clinic.
apreciación
Diagnosis is done
clínica.
by the
Yo tengo
clinical
al paciente,
um,
tengo la
exam. I
anamnesis,
have the
tengo todo
patient, I have
listo
the
y ya la
amnesis. I should
sospecha, la
already
alta
have the
sospecha
high
diagnóstica,
suspicion
que
of
puede ser o no
a
confirmada
diagnosis,
con
which
el
might be or
electrocardiograma
not
y no
confirmed
voy a
with the
esperar la
ECG. I'm not
troponina, el
going to wait for the
resultado de la
troponin. I'm
troponina
not
para
going to
tomar
wait for
acción.
the
Podría
troponin
demorarme
result to
20
take action.
minutos,
It might take
media hora,
us
que se
20
me juega
minutes,
la vida
half
del
an hour,
paciente.
which
Es
means
cierto que la
the
troponina
death
tiene
of
una
a
precisión
patient.
diagnóstica
It's
y
true that the
pronóstica
troponin
y
has a
además las
diagnostic and
medidas
prognostic
seriadas me
precision,
ayudan
and
a
the
evaluar cómo va
serial
mi
measures help
paciente,
me to
cómo
evaluate
va
how my patient
evolucionando.
is doing,
Pero
how
yo
he
no
or
debo
she is
esperar
evolving. But I should not
porque
wait.
debo tomar
I should not
decisiones
wait
en
because I
cuanto
need
a
to
la
make decisions
estrategia
with regards
terapéutica
to the
que voy a
therapeutic
tomar.
strategy that I
Puede
will
ser que yo
take. It
tome
might
una
be
estrategia
that I take
terapéutica
a therapeutical strategy
farmacológica,
that it's
que es la que
pharmacological,
podría
which
estar a
is
la
the
mano
one that
en
might
todos los
be
centros
at
donde el
hand
paciente puede
in
llegar.
all the centers where a
Pero
patient might
también
arrive.
podría ir a la
But I
estrategia
might
terapéutica
also go to
invasiva
the
si es
invasive
que
therapeutical
sé
strategy
que
if
cuento con un
I
hospital
know that I
cercano
have a
donde yo
close
puedo hacer que me
hospital or
reciban al
nearby hospital
paciente
where
y que
my
le
patient
hagan
can go
inmediatamente
and
un
the
cateterismo,
patient can
una
immediately get a
intervención
catheterism
subcutánea,
and
una
percutaneous
angioplastia y la
intervention and
colocación de un
angioplasty
stent o más
and the
stent
placement
según
of
sea
a
el
stent
caso.
or more, depending on the case, of
Entonces,
course. So
importa pues
it is important.
saber
It is important to know,
diagnosticar en
to
cualquier
diagnose
lugar que
in
sea
any
un
place
centro de salud.
that it's a
Saber
health
tomar
center.
acción.
We
Si no
need to
sé
take
leer el
action. If I don't
electrocardiograma,
know
lo
how to
puedo
read the
mandar por
ECG,
video, por
I
WhatsApp
can
o
send it
por
by
cualquier
video, by
medio a
WhatsApp, or
un
by
lugar
any
donde
means
deban
to a
recibirme el
place where they
electrocardiograma y
would
tener una
receive my
respuesta
ECG
inmediata
and
para
they will
saber
give me an immediate
qué
response
acción
to
tomar.
know what
Ustedes
action
saben
to take.
que el
You
paciente
know that the
siente el dolor
patient
y
feels the pain,
podría
and
tomar la decisión en
they
ese
might
instante
make
de
the
ir a
decision
una
at that
institución de
point to
salud
go to a health
o podría
facility, or they
tomar
might
otros
maybe take
medicamentos,
uh, may
recibir
take
medicamentos
medication, receive a, a homemade medication, her neighbors, and or it is at the level where we miss time because of a delay of the patient, of the patient himself, and then feel worse, and then they will go to the health system, or they might call a ambulance, or they might call
sistema de
a
emergencias.
an emergency system, who knows?
Si acude a un centro grande,
If the
pues
patient goes to a
frecuente
large
ese
center, well,
centro
maybe that
con todas
center with
las
all
mediciones
the
clínicas, el
clinical
electrocardiograma,
conditions, the
podrá
electrocardiogram, and
quizás tomar una
everything, they
decisión para
might
una
make
estrategia invasiva.
a decision
Pero
to
eso
have a
significa que en los niveles
invasive
de atención
strategy. But
primaria,
that
la
means that
atención ha
the
sido correcta e
care
inmediata.
has
O
been
quizás
correct
el
immediately at
paciente
the primary
pudo
level, or
llegar de
maybe the
frente a este
patient
hospital,
managed to get directly
fue
to this
evaluado en
hospital.
emergencia y
He was
rápidamente
evaluated
llevado
in the
a la
emergency and
sala de
rapidly taken
hemodinámica y en
to
menos de
the
60
hemodynamic room,
minutos,
and in
que es el
less than
tiempo ideal, está
50
ingresando a la
60
sala de
minutes, which is the
hemodinámica
ideal time,
para hacerse
he is taken
cateterismo.
to the hemodynamic room to
En cambio,
receive an
podría ir a su centro de
catheterism,
salud
but
más
the patient
cercano o
might
a la
go to the
ambulancia.
closest health center or
Y
the
allí
ambulance, and
va a
there
tener una
they
nueva
will
evaluación
have
médica
a new
y allí se
medical
podrá tomar,
assessment,
si bien
and
es
there
cierto, el
they will
paciente,
be
la
able, if
decisión
the
en la
patient
ambulancia
is
de
lucky,
iniciar una
that they might
trombolisis
make
ya con el
the decision in
diagnóstico,
the ambulance of starting a
o en el
thrombolysis with the
centro.
diagnosis,
Si
or in
el
the center, in the
centro,
health center.
la
If the center,
institución
the
que recibe al
institution
paciente
that receives the patient
sabe
mm,
que va a lograr
knows
un
that
cateterismo cardíaco
they
en
will
menos de 120
a
minutos,
cardiac
pues
or heart
debería
catheterism in less than
administrar los
90 minutes,
antiagregantes
then they should
plaquetarios y los
start in
anticoagulantes y
the
enviar al
anticoagulants
paciente
and
para una
antiplatelet
angioplastía
aggregants
peritoneal.
to send the patient to a
Si
primary
sabe que no va
angioplasty.
a poder
If they
lograr
know that they won't be
este
able
tratamiento
to achieve
en menos
treatment
de
or to
120 minutos,
less than
podrá
120
escoger
minutes, they might
la
choose
estrategia de la
the
fibrinolisis.
strategy of
Este
fibrinolysis,
tiempo
maybe.
entre el
This time, the
electrocardiograma y la decisión de
ECG
hacer la
and the time
fibrinolisis
to do the
debería ser
fibrinolysis
menos de 10 minutos.
fibrinolysis should be less than 10
Es
minutes.
decir, he
That
recibido al
is,
paciente, he hecho la anamnesis, le hice el
have the
electrocardiograma, he
patient
tomado las
ID
muestras
amniotic,
y ya estoy
the sample, and
tomando la
I am
decisión. Sé que
already
mi centro
making the
no, mi
decision. I know
paciente no
that
va a
my
llegar en
patient
menos de
wants to
120
get
minutos
there in less than
a la
120 minutes
instancia superior o
to
a la
the
instancia
higher
más grande
instance
donde
or
le
the
podamos hacer un
largest hospital
cateterismo
where he can get a
inicio la
catheterism, then
trombolisis.
I'll start
Esa
thrombolysis.
trombolisis me va a
That
tomar
thrombolysis
una
will
hora
take me 1 hour.
y luego de eso,
And
de
then
haber hecho la
after that,
trombolisis,
after doing the
puedo
thrombolysis,
trasladar
I
al
might
paciente
transfer my patient to
al Instituto de
the
Salud Superior para
higher
que sea
level health
reevaluado
center
y
so that
decidan si se
he is
va
going
por
to be
la
reevaluated, and they would decide
estrategia
there if
de
they
la
would
fibrinolisis, de la angioplastía, es decir, si
if
se
they would
hace
do an
cateterismo,
angioplasty,
pero
that
que
is,
de
if they
todas
will do
maneras un paciente que
catheterism. I think
recibió
that anyway, a
fibrinolisis
patient that
debería
has
ir a un
received
cateterismo y tomar la decisión
fibrinolysis should
si
have
se
a
procede con la
catheterism.
angioplastía
But
o no.
they are the ones that will
Fíjense
decide whether
cómo
to
se
continue with the
recomienda
angioplasty or
la
not. Look
medición
how
de los
uh,
tiempos
we
para
recommend the
evitar el
measurement of the
retraso.
times to
El
prevent
retraso no
delays.
solo del
Delays
paciente,
do
el
not
retraso del
only for the
sistema.
patients, but delays
Nuestros
in the system,
sistemas
actually. Our
a
systems,
veces,
sometimes,
por mil razones,
for thousands of
sea en el
reasons,
público o en el privado, ocasionan
whether
un
in public or
retraso en el
private, will
tratamiento.
result in a delay
Por
in the
lo tanto,
treatment.
tenemos que luchar para que
Therefore, we need
estos
to
tiempos
fight for
se
these
acorten.
times to be shortened.
Es importante que en los centros de salud
If
primarios
it is important that in
sepan
the
que sí
primary
pueden
healthcare
administrar
center
fibrinolisis. Es
they
una
know that they can
estrategia de importante
administer
repercusión. ¿Cuántos
fibrinolysis. It
centros
is
de
an important
hemodinámica
strategy.
tenemos en
How
el
many
país?
hemodynamic centers do we have
Nuestra
in the country?
realidad no es
In
diferente a
reality,
la
it's
realidad
not
de todos
different
los
from the
países de
reality of
Sudamérica
all the South American
ni de
countries
Centroamérica,
or Central
ni
American
tampoco de
countries,
México.
or
En los
not even
trabajos
from
que he
Mexico.
revisado,
In the
la
work that I
realidad es
have,
similar. El
the
tráfico que
reality is
existe en
that
Lima
the
existe
traffic
también en la
existing in
Ciudad de
Lima
México,
exists
en
also
Sao
in the
Paulo,
city of
en
Mexico,
Buenos
in Sao
Aires,
Paulo, in Buenos Aires.
mayores o menores facilidades. Así que
So
la realidad en salud
the
es muy
reality in
sencilla.
health is very similar.
Y recordar que la
Remember
fibrinolisis
that
bien hecha
analysis,
previene
if it is well
30
done, it
muertes
will prevent
prematuras por
30
cada 1000 pacientes
premature
tratados
deaths
en las
for
primeras 6 horas de
1,000
presentación de
patients treated in the
síntomas.
first 6 hours after
Ofrece
symptom
mejoría
presentation. It
significativa de los
offers
síntomas
significant
isquémicos
improvement of the ischemic
y
symptoms,
ofrece también la
and it
resolución
also
del
offers
electrocardiograma,
ST
que no
segment
es lo importante.
resolution,
Lo
which is
importante
not
es
what
obtener una
matters. What
estabilidad
matters is
hemodinámica
to get
y
a
ofrecer
hemodynamic stability and
salvarle la
offer
vida al paciente.
saving the life of the patient.
Cuando la fibrinolisis es la
When
estrategia de
fibrinolysis is
repercusión,
the
entonces tenemos que empezar lo
repercussion
más
strategy,
rápido
we need to
posible.
start as fast as
Existen
possible.
en
There
el
are
mundo muchos
in the
antibióticos
world
trombolíticos. En el
there are
Perú
many
tenemos más al
thrombolytics. In
alcance
Peru, we
uno,
have uh,
Alteplasa, que es un
Alteplasa,
trombolítico, que quiere decir que
which is a
disuelve el
thrombolytic,
trombo
which means that it
y
dissolves the
que
thrombus,
se puede
and which
administrar de
can
manera
be
muy simple,
administered in a
dividiendo
very
un
simple
frasco
manner
en
by
100
diluting
centímetros,
a
calculando la dosis de
capsule
0,9 miligramos por kilo
100
para administrar al
centimeters, calculating
paciente, un
the
modo
dose of
del 10%
0.9
de la dosis, es decir, 10
mgrs
mililitros,
kilogram
que es muy rápido y en 90
in
instantes lo
in 10% of the doses rapidly, and the rest in 90% in 1 hour. Of course, the patient needs to be monitored, needs to be surveilled. The patient needs to have been given and which are very accessible drugs nowadays all over Peru. Likewise, this is to start an anticoagulation with subcutaneous enoxaparin with non-fractionated heparin if we do not have enoxaparin with a level of evidence 1A. Subcutaneous is not used any longer as, but there might still be places where they have availability of these drugs. Uh, in this streptokinase hotel place, the plus and place is streptokinase has a lower efficacy, and therefore we have express alteplase and ecteplase or reteplase. What other drugs do we recommend having in a primary healthcare level? Well, if the patient is hypoxic, yes, of course, I need to give oxygen with a cannula. If the patient has a normal breathing, not agitated, doesn't have presentation, doesn't have signs or evidence of an hypoxemia. Nowadays that we have this deterioration as saturation under 90, they do not need. But if there is hypoxemia, yes, that will help. Nitrate will be useful always that the systolic high BP is higher than 100. Be careful that we cannot give it to a potent patient, and a patient that is getting allergenic shock might have with a single manifestation many times a high blood pressure. The opiates can be used to relieve pain, which is very intense. You can use morphine and IV carefully, of course, because sometimes that might create nausea or vomiting, or sometimes an unnecessary effort in the patient. We can give relaxation or drug relaxation to the patient, and it's important in that case to use beta blockers. Beta blockers, why? Because they save oxygen, they save the bending, they decrease the strength with which the heart is being contracted, and if the patient has a higher heart frequency more than 100, they will be very, very useful. However, we should always look at the ECG, looking for blockages, looking whether the patient is bradycardic for not administering this drug. Simultaneously, we will preparing the post thrombolysis transfer to a center where they can do a catheterism and angioplasty, and maybe placement of a stent or more stents. We should not delay the patient, but please look at all the actions that might be taken in a primary healthcare center. Something things that are very, very important, but with a high level of responsibility. What concomitant medication should I have at hand to start? It's since the moment I receive the patient aspirin, 150 to 300 milligrams initial dose. Clopidogrel T2Y inhibitors, allowing dose of 300 to 600 milligrams, followed by 75 milligrams per day. Beta blockers, the most commonly used, metoprolol, EV, and bisoprolol. We also have, when we don't have metoprolol IV, we have the oral metoprolol. Statins, we have proven that statins can even favor the regression of the plaque and stabilize the endothelium to decrease the inflammatory process in the endothelium. We start in an acute infarct with 80 milligrams a day, low molecular weight heparin based on the weight of the patient, and in absence of this, we can use a non-fractionated heparin. And let's not forget, in patients that have a good blood pressure, the use of enalapril, ramipril, or lisinopril, whatever we have available, or an RF second, like candesartan. Let's remember that the ACE inhibitors decrease the systemic vascular resistance. That is, they help to the heart work. They help to prevent cardiac insufficiency. All these drugs should be available. We should only know the high-risk criteria in acute myocardial infarction. Which are these criteria, or the gray criteria? Hemodynamic instability that might lead to cardiogenic shock, persistent chest pain, or recurrent. A patient that has received thrombolysis with chest pain, we have to transfer this patient immediately, despite the fact that we have even given the thrombolytic treatment, the acute heart failure which might be secondary
miocardio-hipertensión
to the
puede ser
myocardial
incluso
ischemia, or
un
might
daño
be
del músculo
even due to a
capitular
damage
que
in the
genera disfunción
sternopapillary
valvular.
muscle that generates mitral
Atentos a los
vascular
arritmias
disease,
potencialmente mortales o al
arrhythmias,
paro cardíaco.
potentially
Puede
mortal
haber paro
arrhythmias or
cardíaco en
heart
las primeras horas
arrest.
con
There might be
mayor
heart arrest in the
frecuencia.
first
Por lo tanto, el
hours more
personal de salud
frequently. There,
también debe
the
estar
health staff
entrenado
should
para
also be
asistir,
trained
para
to
brindar
assist
reanimación
to provide
cardíaca
cardiac
básica y
reanimation
también reanimación cardíaca
and also
avanzada en el caso
advanced
de que existan
reanimation
médicos
in case
alrededor.
that there in case there are
Pueden haber
physicians around.
complicaciones
There might be
mecánicas,
also
es decir,
mechanical
puede haber
complications,
ruptura del
that is, there
miocardio
might
por
be
disfunción del meneo
myocardial
valvular mitral,
rupture,
puede haber pericarditis,
might be
pueden haber
pericarditis.
cambios
There
dinámicos
might be
recurrentes en el
dynamic, electrical
electrocardiograma y
dynamic changes in
cardiosis
the
isquémica.
ECG that
Esos
indicate
son
the
los
peak. That
criterios de
those
alto
are the
riesgo.
high risk
El
criteria.
tratamiento invasivo
Treatment,
en
the
el
invasive
síndrome coronario
treatment
agudo
in the
es
acute
la
coronary
estrategia de escoger
the
la
strategy of
angioplastía
choosing
primaria,
the
que es una
primary
angiografía
angioplasty, which
inmediata
is an
seguida de
angioplasty,
intervencionismo
followed by
percutáneo. Esto está
percutaneous
muy
intervention,
próximo a la
and this
atención
is
primaria.
very
O sea,
close to the
fíjense,
primary care. Two
lo
steps.
ideal es recibir al
We
paciente,
also
reconocer
to
el
receive the,
diagnóstico y
recognize the
referirlo a una
diagnosis and
institución
refer the
donde
patient
puedan
to
hacer
an
un
institution
cateterismo.
where they
Reconocer que
can
el
get a
paciente haya llegado
catheterization
a la
and
emergencia donde
not the ER
existe el
where
cateterismo cardíaco.
they have the
Si
heart
está
catheterization.
indicada, preferida, hay
Is
que hacerlo.
indicated
No hay
in
que
the-
dudarlo.
to be done. Let's
En
not
los
doubt about
primeros
this.
100,
Let's not
20
hesitate about
minutos
this. In
desde
the
el
first
diagnóstico
120
basado
minutes
en la
from
evaluación
diagnosis
inicial.
based on the initial assessment.
Es cierto que el
It
intervencionismo
is true
percutáneo es
that
superior a la
percutaneous
fibrinolysis
interventionism
en
is
cuanto a la
better
reducción de
than
mortalidad, reinfarto no fatal y
fibri-
arritmias. Lo que
fibrinolysis
pasa
in
es
terms of the
que esto
mortality
tiene que
reduction,
ver con los tiempos.
infarct, or
Si yo
it
voy a trazar a
as
mi
with times is
paciente
going to
para que
delay
el
my
cateterismo sea
patient
hecho
for the
al
catheterism
día
to be
siguiente,
done
ya
next day.
debería haber hecho la
Well, should
fibrinolysis,
have already
porque
done
ya al
the
día siguiente no va a ser igual el
fibrinolysis
tratamiento
because
invasivo.
the next day the
Y para
invasive
fijar
treatment
mejor
will
esta
not be the
idea,
same.
les
And to fix
presento
better
aquí
this idea, I
un
will show you
estudio
here
de
a
cardiología
study
nuclear en
of
un infarto
myocarditis
agudo.
in an
Fíjense cómo
acute.
falta. Estos son
You can
cortes del
see
corazón.
these
Este
are
es un
cuts
corte
of the
transversal
heart.
donde
This is a
a través del eje
cross-cutting
corto
cut through
podemos
the
ver en rojo el
short
tejido
axis. We can
sano,
see in red
en
the healthy
amarillo
tissue,
el
in
tejido que
yellow
ya no está
the
sano y
tissue
la
that is
pérdida
not
del
healthy any
tejido
longer,
verde.
and the loss of tissue in green.
Y cómo después de
And how
revascularización
after the
volvemos a ver un
revascularization,
miocardio
we see
completo.
again a complete
Aquí una
myocardium.
arteria obstruida,
Here,
que es lo que
this
se
is an
consigue con
obstructed
el
artery,
cateterismo.
which is
Ver
what
la arteria o
you
las
get
arterias
with
con
catheterism. You can
pérdolas,
see the
descubrir la arteria
arteries
culposa
that
y
uh,
tratar la arteria que es
that
culpable
are
del
causing the
infarto,
problem
si es
and
que es una
treat this
angioplastia primaria. Si está el
artery.
paciente
If it is a
inestable, le harán
primary
solo la angioplastia
angioplasty, if the
de la
patient
arteria
is
culpable y
unstable,
las
they will
otras las
only
dejarán
do
para
the
después.
angioplasty of this
Pero
artery and
como
they will
este
leave the
paciente
others
tiene
for
su
later.
coronario
But
derecho
since
muy
this patient,
enfermo,
the heart
entonces el
coronary is
intervencionista
very
tomará la decisión
sick, so
de si
the
hace
hemodynamist will
la
make a
angioplastia
decision
primaria de
whether
la
to the
arteria
primary
culpable o
angioplasty
revasculariza
of
más
the
arterias.
main artery, or he will
Entonces, la
revascularize
angioplastia
more
primaria,
arteries.
lo
So the
ideal,
primary
según las
angioplasty, the ideal thing
recomendaciones
based on the
de la American Heart
recommendation of the
Association,
American Heart
del
Association,
ACC,
of
de
the
la Sociedad
ACC,
Europea de
of the
Cardiología, idealmente
European
debe
Society
ser
of Cardiology,
en menos
ideally
de
should be in less
120
than
minutos.
120 minutes.
¿Hasta cuándo puedo
Up,
esperar? Máximo
how
12
much can
horas
I wait?
cada
Well,
vez
the
para
top is 12
poder
hours. What for?
salvar
To be
más
able to
miocardios.
save
Cuanto
more
más rápido lo
myocardium.
haga,
The
más
faster I
miocardio
do it,
salvo,
the
menos
more
cicatrices
myocardium
voy a
I
dejar
will
en el corazón.
save less
La
scarring in
angioplastia
the
de
heart.
rescate
It
es aquella que
rescue
se hace
angioplasty
post-trombolisis
that is
fallida.
done
Le
post
administré la
thrombolysis
trombolisis,
and has
el
failed.
paciente
I
sigue con
gave
dolor, lo evacúo de
thrombolysis, the
inmediato,
patient is still
completamente
painful.
monitorizado
I
a la sala de
send the patient
hemodinámica, al centro que
to
tenga
the
hemodinámica y se le
hemodynamic
hará una
center,
angioplastia
and he
de
will have
rescate.
an rescue
Cateterismo con
angioplasty and
miras a
catheterism
rescatar la arteria
in
que está
order to
obstruida y
rescue
rescatar
the
el
artery
miocardio
that
que
is
queda, porque algo
obstructed
debo haber
and
perdido de
rescue the
las horas
myocardium,
o los
because
minutos que han
something
transcurrido.
I might have lost after all this time.
También se acepta el intervencionismo tardío,
Late
12 a
interventionism
48
is
horas
also
después del
accepted
inicio de los
12 to
síntomas, como
48
es lo
hours
ideal.
after the beginning of the
No
symptoms. It's
olvidar que
not
muchos
ideal. Let's not
pacientes pueden
get that
requerir
many
cirugía de
patients have
revascularización
uh,
miocárdica y esa
myocardial
cirugía muchas veces
revascularization
tiene que
surgery, and that
establecerse de
surgery many
manera
times
urgente
is
para los
established
pacientes
urgently for
que tienen
patients that
complicaciones
have
mecánicas asociadas
mechanical
al infarto agudo
complications
de miocardio.
associated to acute myocardial infarction.
Pacientes con shock cardiogénico,
Patients
con
with
disfunción
cardiogenic
mitral aguda
shock, with
isquémica, con
acute
ruptura del
ischemic
miocardio,
shock dysfunction,
pacientes que
with
tienen que entrar a
myocardial
sala
rupture,
inicial a
patients that need to
medianoche
go to
para
the ER or
salvar
to the OR, even at midnight. What
Esos
for? To
pacientes quienes
save
han
their lives.
fracasado en la
Patients with
angioplastia primaria,
primary
condición
angioplasty
aguda
have
no
failed
tratable mediante
with the
angioplastia,
acute occlusion
aunque
that
no es
cannot be treated with
frecuente, se
angioplasty, even
benefician
though
con
it
la
is not, and they
revascularización.
will benefit with the surgical
Lamentablemente,
revascularization.
ocasiona más
Unfortunately,
atraso y por
that
lo tanto a
will
veces
cause
menos
more delays and
cardiocefalo.
therefore sometimes less
No
safe
olvidemos,
myocardium. Let's not
nunca,
forget, never
el
forget
paro cardíaco
that
o la
heart
fibrilación
arrest or
ventricular,
the
aquí le decimos al
ventricular
corazón que está fibrillando, es
fibrillation. Here you see
desfibrilación
a heart that
mecánica.
is
El
fibrillated.
corazón
You see that there is
no
no
está
mechanical
cumpliendo con
action.
su
The heart
función de
is not
bombeo como debe
fulfilling its
cumplir.
pumping function as it
Por lo
should.
tanto,
Therefore,
ese corazón
that
no está
heart
enviando sangre al
is not
cerebro ni a ningún
sending
órgano. Por eso es que la
blood to
fibrilación
the
auricular
brain or
es
any
un equivalente al
um,
paro cardíaco.
organ. That's why
Un paciente
this
con síndrome
fibrillation
coronario no
is
puede presentar paro
uh,
cardíaco.
similar to a heart attack. They can have
Y sobre todo,
a heart
muchas
attack,
veces
and
de manera
especially many times
extrahospitalaria.
in an
Y en
extra
Estados Unidos,
outside of the
países
hospital.
altamente desarrollados,
In the US, a
se
very
ha
developed country,
instruido a la
they
población
have
para que
instructed the
sepan hacer
population to
reanimación
know how
cardiopulmonar
to
básica.
do basic cardiopulmonary
Y la reanimación
resuscitation,
cardiovascular avanzada
reanimation,
requiere
and the
para paciente
advanced
ya llegue al hospital y donde se va a
is
usar
for patients that get to the
el
hospital. Well,
endotecipial y
they will
todos los
use the
fármacos.
endotracheal tube and all
Pero
the
para hacer reanimación
um, things,
cardiovascular
but to do
básica, bien hecha,
cardiovascular
basta
reanimation,
de las
basic and well
manos
done, it
y
has to
una
have
buena
hands,
posición del paciente.
a good
Si
position of
la
the patient.
reanimación es
If the
exitosa,
reanimation
si
is
confirmamos el
successful,
síndrome
well, then
coronario
we
agudo,
observe
porque
the
no
acute
solo se puede hacer
coronary
paro
syndrome
con
because
síndrome coronario agudo,
you
pero
cannot
sí es
only
la
have
cosa más frecuente,
stop
se debe
arrest because of
realizar
that,
en
but it's the
estos
most
pacientes una
cause of
cistocardiografía
these
invasiva. Esos
patients. They
pacientes
need to
deben
have
ir a
a
cateterismo una vez que
coronary
no se
test
declare
invasive.
paro cardíaco.
Patients need
Acuérdense
to
que un
go to
paciente con paro
catheterism.
puede hacerlo en un
Let's
centro de
remember that a
salud
patient with
sin
a
costo.
heart arrest
Y el
that can
personal debe
happen in a
saber
health
atenderlo
center
en
in the
paro cardíaco,
hospital, and the
reanimarlo,
staff
ponerle,
should
una
how
vez
to
que lo ha
take care
reanimado,
of them,
ponerle
reanimate
todas
them
las
after
hierbas,
reanimation to
tratar
put the
de trasladarlo de inmediato a un
catheter
centro
transfer
donde se
immediately
pueda
the
hacer
patient
una
to a center when they
sintocolonariografía
can have uh, uh,
invasiva.
invasive
Por supuesto que hay que tener en
coronary
cuenta el
mass.
estado
Obviously, they
neurológico,
need
la
to take
probabilidad de
into account the
supervivencia,
neurological
el
and
riesgo
the
versus el
probability of
beneficio del
survival, the
tratamiento,
risk
¿no? Si se
versus the
trata de un
benefit
paciente
of
de
the
repente
treatment. If a
de
patient
90
maybe
años y estoy muy
90 years
lejos,
old
pues
and I am very
quizás
far away, well,
opte por
maybe
otras medidas.
I will decide to
Pero
use
si
other
yo tengo un
measures. But
paciente
if I have a
con buena
patient
probabilidad de
with a
supervivencia, con
very
un buen
like
estado neurológico que lo
with
he
a very
rescatado
good
del paro,
neurological
debo pensar en
condition
la
that I have
estrategia
rescued
de la
from an arrest, I need to think
revascularización
in the
y
strategy of the
descarto ya un
revascularization
AVC
and try to have an
de
angioplasty.
manera urgente.
Urgent.
La terapia antiagregante plaquetaria
The
puede ser compleja cuando pienso en
anti-platelet
ticagrelor, en
aggregant
clopidogrel, en esos fármacos que a
therapy
veces
might be
solamente
complex
están
when
en
I
los
think
hospitales. Pero
the
yo puedo
drugs that
empezar
are
con
only in the
aspirina,
hospital,
con
but
la
I can
dosis de
start with
cátedra,
aspirin
con los
with the
inhibidores
low dose,
plaquetarios
with
como
the
el
uh,
clopidogrel.
platelet
En
inhibitors like
algunos lugares, ya
clopidogrel.
en
In some
atención primaria,
places in
existe
primary
también
care, they already
ticagrelor,
also have ticagrelor,
pero
but
nosotros podríamos tener
we
en
might
nuestros
have
centros
in our
aspirina y
centers
clopidogrel
aspirin
y
and
poder
clopidogrel,
comenzar
cl-
con esta
clopidogrel,
terapia
and start with
antiagregante
this
plaquetaria
anti
que es de
uh,
ayuda. Podemos empezar con heparina no
platelet
fraccionada
anti-aggregant
o con
therapy we
enoxaparina.
can have
No
with
tiene por qué
enoxaparin or
esperar el
non-fractionated
paciente llegar
heparin.
al
The
hospital
patient
para
doesn't need to
iniciar
wait
con este
until getting to the
tratamiento.
hospital to start this
No
treatment.
es complicado
It is not
ponerle una
complicated
dosis
to
inicial de un
put an
miligramo por
initial
kilo
dose of
al
1 milligram
paciente de
per kilogram
enoxaparina
to the
y
patient of
llevarlo y lo
oxaparin
entregamos al
and take
paciente,
them. And when
comunicar que
we
se le ha puesto
uh,
la dosis, hacer un
hand
pequeño
out the
resumen,
patient,
tal vez
we
mientras uno
indicate
lo
that
va
we
trasladando, hacer
will
un
make a
pequeño
break camera
resumen para
the
que el
transfer,
médico que
maybe
lo recibe
that the
sepa qué
physician that receives
fármacos
the
ha
patient
recibido y
knows
cómo
what
debemos
drug
continuar
he
con el
or she has
tratamiento.
received and how do they continue with the treatment.
Igualmente, el tratamiento
Likewise,
inicial debe
medical
involucrar, si no hay
treatment
enoxaparina,
using
heparina no
oxaparin,
fraccionada, que
fractionated
sí
heparin.
está en el
It is
acceso de todos
also
los centros de salud.
it is available actually in all
Una
health
vez que
centers
nosotros
or
hemos
should
puesto
be
la
available.
dosis inicial
Once
y
that we
tenemos
have
los
given the
resultados de los
initial dose and we
análisis,
the
podemos
results
pedir
of
un
the analysis,
hemograma, una
we can have
creatinina, en fin, para poder
creatinine,
ver cuáles van a ser
medical
las dosis subsiguientes y poder
target
conocer un
of
poquito mejor
the
a nuestro
frequent
paciente.
doses
Pero la
and to
dosis
know our
inicial
patients
es la
a
dosis que
little
le va a
bit better. But the
salvar la vida.
initial dose is the dose that will save key for
Hay
her life.
muchas combinaciones
There are
de
many
tratamiento
combinations
antianginoso,
of
pero
anti-anginous
podemos
treatments
disponer
that
al
we
menos
might
de un beta
have
bloqueador bien
at least
indicado
one
para
blocker well
utilizarlo en la
indicated
fase aguda.
to use it
Después,
in the
en los
acute phase.
otros niveles de
Then
atención,
in the other
podrán
levels
utilizar
of
los
care,
inhibidores
they
de
might use
calcio, diltiazem, en
calcium
fin, según sea el
blockers, well,
caso.
whatever,
El
based on
beta
the
bloqueador,
each case.
fíjense
The beta
ustedes, debe
blocker you
estar
can
desde el
see here
primer
must be
nivel, desde el
from
primer paso
should
que
be
se da
from
en
the
aquel
first step,
paciente a
but
quien
it's
tratamos con
given
insuficiencia
with a
cardíaca.
patient with a heart
Los otros fármacos se
failure
pueden
that
ir
we treat. The
añadiendo en
other
los
drugs,
otros
you can add
niveles de
them little by
atención, pero
little in the
tenemos que
other
conocer que
levels of
existen
care, but
y tenemos que
we
hacer
need to know
educación
they
con nuestro
exist. we need to
profesional de salud para
educate
que
our
sepan
health staff
actuar y
so that
tomar
they know how
decisiones.
to
El
act and how to
beta-bloqueador
make
busca
decisions. The
reducción del área de
beta blocker
infarto, reducción de la tasa
looks
de
a
ruptura
reduction in the area of
miocárdica.
the infarct, reduction in
Y
the
eso
rate of
debe ser
myocardial rupture,
desde
and
el primer
they
día y
should
si es
be started
posible
from
desde
the
el
first
primer
day, and if
instante
possible,
para
from the first instance to
incidencia de
even
un
reduce the
infarto
incidence,
y
the
el
post-infarct
reinfarto.
angina and re-infarct.
Pensando en poder
Thinking
minimizar
in
el
being able
tiempo
to
de atención del
minimize the
paciente,
time it
porque a
takes
veces
to
en
provide
emergencia
care
hay
to the
muchos
patient, because
pacientes
sometimes in
se han
the
creado
ER there
las
are many
unidades de
patients
dolor
to
torácico,
take care
con el
of.
objetivo
We have
desde
created
ya
these units of
protocolizar, optimizar la
chest pain
asistencia al
to
paciente con dolor
protocolize
torácico
and
agudo y
optimize the care
existir
of
una
the
unidad
patient with acute chest pain
especializada
in emergency.
donde se
This is a
ocupa detectar
specialized unit in which
rápidamente el
they
síndrome coronario de alto
seek to rapidly
riesgo para
detect
no
the high
tener
risk coronary
intervención
syndrome for not having any
y
delay,
sobre todo para buscar la
especially to
reperfusión
look for
urgente,
the
es
urgent
decir,
reperfusion, that is,
sea trombolisis o sea
whether it is
angioplastia,
thrombolysis or
sobre todo
angioplasty,
cuando sospechamos de una
especially when we
elevación del
suspect of
segmento ST.
ST segment elevation acute
En los demás
myocardial
pacientes
infarction.
también
In
se
the
puede
other
evaluar
patients, you can also evaluate or
que
assess
el dolor torácico agudo no
that
es
the acute chest
del
pain
corazón, que es de
is
otro
not from the
órgano y hay
heart,
que
it comes
evitar
from a different
complicaciones más
organ,
graves.
and to prevent
Pero este
unnecessary
espacio, esta
admissions. But
unidad de
this
dolor
space, this
torácico
unit, this
debe tener un
acute
espacio
chest
físico
pain unit should
dedicado
have a
a lo que
physical
es dolor
space
torácico. Debe
devoted or
estar
focused
plenamente
on
equipado. Y cuando
chest
digo
pain should
plenamente
be fully
equipado,
equipped. And when I
digo
say
que debe
fully
tener
equipped, I mean that
elementos en
it
el
should have at
electrocardiógrafo
least
in
an
situ,
ECG machine on
un
site, a
cardiodesfibrilador para
cardio
poder
defibrillator,
administrarlo
to
al
be able
paciente cuando está
to
paro y cuando sea
uh,
necesario.
use it in the patient if they have an arrest or if
Y debe tener
necessary.
un
And they
personal
should also have a staff
bien
that
capacitado,
is
un
well
personal
trained,
que sepa
staff
colocar
that
una guía,
knows
que
how
sepa
to
manejar
put an
infusiones, si tiene bomba
catheters,
de
that
infusión, que
knows how
sepa
to
manejar
manage an
la bomba de
infusion. If they have
infusión, que no
infusion
nos
pump,
atrase
that
una
know how to
guía
do
porque no
that,
la
that
podemos
doesn't
poner,
delay
que
take much
sepa
time
tomar un
putting
electrocardiograma,
a catheter,
que
that
sepa
knows how to take a
transmitirlo también,
ECG, that
si en
knows how to
caso no estamos
transfer
en
them as
disponibilidad
well if we
inmediata.
are not in a
Por
place where we
suerte,
have a cardiologist.
hoy por hoy están
Fortunately,
aumentando el número de
nowadays,
cardiólogos y
there
creo
is
que
a
la
high
mayor parte
number
de
of
hospitales
cardiologists, and
tienen
I think that
cardiólogo.
most of the hospitals
Esta área
nowadays
se
have a
ubica en el
cardiologist.
centro de
This area
emergencias.
is in the
Sirve para activar
emergency
el
center.
sistema.
It
El sistema tiene que ser
activates the
activado.
system. The
Todo el
system
sistema,
needs
desde el
to be
portero que
activated. The
está
whole
afuera,
system,
tiene que
from the
saber cómo
doorman that
activar
it's
un
outside, they
paciente con
need to
dolor
know how to
torácico
take
para
care of a
reducir
patient with chest
al
pain,
mínimo el
to
tiempo de
reduce at the
demora en la
minimum
realización del
time
diagnóstico.
that it takes to provide
Monitorear
a
al
diagnosis,
paciente,
monitor the
estar
patient,
pensando
to
en que
be
ese paciente
thinking
puede tener una
in the
taquicardia
fact that
ventricular
these
o un paro y
patients might
estar
have a
atento
ventricular
para
tachycardia
frenar
or a
desfibrilación
rest
si
and
fuera
be
necesario.
paying attention to do a defibrillation if
Y si tiene un
necessary.
servicio de
And
hemodinámica,
if there is
prepararlo,
an
ya no para
hemodynamic service,
trombolisis,
to
sino
prepare it
para
not for the thrombolysis, but
ingresar a la sala de
to
hemodinámica
uh,
si mi hospital tiene
take
hemodinámicas
the patient to the
o
hemodynamic room if
trasladarlo a
my
un hospital.
hospital has it, or transfer the patient
Esta
to
es
a
realidad
hospital. This
de los tiempos,
is
los
the reality
atrasos
of
de
the
los
times,
tiempos.
the
Todo
delays
esto
in the times,
se
and
da
all of
en
that
todos nuestros países
happens
y
in
aún
all of
en
our
el mundo
countries and
desarrollado.
even in the
Así
developed
que
world. So
quiero
I
mostrarles
want to
algunos
show you
estudios que se
some
han hecho
studies that have been
a
done
nivel nacional, que son estudios
at
muy
the national
valiosos.
level that are
RENIMA
very
que lo hizo
valuable
la
study.
Sociedad Peruana
RENIMA,
de
which was
Cardiología
done
a
by the
nivel nacional,
Peruvian
haciendo
Association
caso
of
de todo el
Cardiology
Perú.
countrywide,
Persemi
gathering
1
cases
fue
from all the
la
from Peru.
motivación fue de los
For
médicos
SEMI
de
one,
la
the
seguridad
motivation
social,
here was
Persemi
the
1 y
physicians
Persemi
of the
2,
Social Security,
para
PSEMI
evaluar las características
1 and 2, to evaluate
epidemiológicas del
the
miocardio y
epidemiological
el
characteristics
tratamiento de
of
un
the
infarto agudo en dolor.
uh,
Es importante que
myocardial
sepamos que
infarction and its
conozcamos
treatment.
estos
It is
estudios
important that we know these
para
studies, that
poder
we are aware of them,
conocer
to
un
be
poco
able
nuestra
to get to
realidad y
know
cómo
a
nos
little bit
estamos
of our
moviendo en el
reality
mundo.
and
Ustedes
how
saben
we
que el
are
Perú
doing
tiene
in
una
Peru. You know
geografía
that Peru
difícil.
has a difficult
El viaje
geography.
a veces es
Um,
difícil para el
Sometimes
paciente.
traveling is
La
for a patient is
gestión
very
es
difficult.
difícil también.
Management is difficult as
Entonces,
well.
tenemos que
So we
prepararnos
have
para
to
poder
get
mejorar la
ready. We have to
mortalidad del
prepare to
infarto
improve
agudo en el Perú
mortality or the
y
result
mejorar
in
los
terms of
eventos
mortality of the
adversos
acute infarction in Peru,
intrahospitalarios.
and improve the
Ahí está el nombre de los
intra-hospital
médicos que
adverse
han
events. This
liderado
is
este estudio, pero son
the
muchísimos más.
physicians that have led this
Fíjese que
study,
han
but there are
recogido
many
el
more.
5% de pacientes
Uh,
de
they
Chiclayo, de
have
Cajamarca
5% of
3,
patients from
Lima es el
Chiclayo, Cajamarca 3,
58%,
Lima
el Callao
51%, Callao
27%,
27%,
Huancayo, Cusco, Ica,
Cayo,
Arequipa y
Cusco,
Juliaca también
Arequipa,
participaron.
Yaca
Y
also
también, al igual que
participated,
en
just
México, en
as
Estados
in
Unidos y
Mexico and
Brasil,
the United
la
States,
incidencia fue
Brazil,
mayor en el sexo
incidence higher
masculino, pero
in
a
males,
más edad
and
ya se cruzan las líneas
older,
y la
the lines
participación femenina es
uh,
discretamente mayor
closer
a mayor
together
edad.
across.
¿Qué nos muestra? Que las estrategias de
What does this
repercusión en
show
estos
about the
pacientes,
reperfusion strategies
fíjense,
in
el
these patients? Look,
66% se
66%
beneficiaron, sea con
benefited,
trombolisis o sea
whether with
con
hemolysis
estudios
or
de
with
cinecoronariografía. 44,
coronography study,
34% no recibieron
34%
ningún
didn't
tratamiento, ninguna
receive
reperfusión.
any
Triste,
reperfusion.
¿verdad? No puede
Very
ser,
sad, right?
tenemos que
It
mejorar
cannot
eso.
be. We have to improve this.
25%
25%
tuvieron
had
fibrinolisis y
fibrinolysis and
Angioplastia primaria,
angioplasty.
19%.
Primary
Acuérdense que esto, muchos de
angioplasty,
nuestros pacientes ya
19%.
han
Let's
tenido
remember
la
that many of these
fibrinolysis.
patients are taken care of in
Fibrinolysis
the
sola,
Social Security. Oh,
10%.
fibrinolysis alone, 10%.
Angioplastia primaria entre las 12 y
Primary
48 horas,
angioplasty
9%.
between 2 and
Y
48
los
hours,
tiempos,
9%, and the
los tiempos son
times as well.
óptimos.
These
4
time are
horas desde que
optimal,
inician
4
los síntomas
hours
hasta
since
la
the
fibrinolysis.
symptoms started to the
Claro, queremos
fibrinolysis.
que
Well,
sea 10
yes, of
minutos,
course, we want it to be 10
preferiblemente
minutes,
4 horas.
but you can see here,
Inicio de los
it's 4
síntomas,
hours.
2.5 horas hasta el primer
Onset of
contacto médico.
symptoms, 2.5 hours to
2.5
the
horas
first
hasta la
medical contact, and
fibrinolysis.
1.5 hours to
Y aquí, hasta el ingreso al
fibrinolysis.
centro.
And here, until the
Es
admission to the center,
3.5 horas más
3.5
2.5 horas,
hours plus
6 horas.
2.5 hours, 6 hours.
Y de ahí a la
And
angioplastia
then
primaria.
the primary
Entonces, estos
angioplasty.
tiempos
So these
son
times are
nuestra realidad.
our
¿Por qué
reality.
falló? ¿Por qué
Why
falló
it
en el
failed?
estudio
Why
realizado
did
por
it
estos
fail in
científicos?
the study done by these
La
physicians?
presentación
Well, the
entre 24 y
presentation
72 horas,
between 24 and
peor
72
mortalidad.
hours,
Falta de
the
angiógrafo,
poor mortality, low of angiograph
20%.
machine,
Presentación más de 12
angiography
horas,
machine 20%,
13%.
presentation more than 12 hours,
Falta de
13%, lack
fibrinolíticos,
of fibrinolytics
8%. Error
8%,
diagnóstico, que
diagnosis
no debería
error
ocurrir,
that should not happen
6.5%. Los demás porcentajes
6.5%,
son
the other
menores.
percentages are lower.
Entonces, esta es otra
So
forma de
this is
presentación de cómo
another
fue
way to
las
present
estrategias de
how
reperfusión en este
the
grupo de pacientes
strategies did in this group of
y
patients
el tipo de intervención
and the
que
type of
realizaron en
intervention that
este grupo de
was
pacientes.
done in this group of
Por lo
patients.
tanto,
Therefore,
quiero concluir
I want
diciéndoles lo
to
siguiente. La
wrap
enfermedad
up my
coronaria es
presentation
la
saying
principal causa
saying
de
following
muerte
coronary
por
heart diseases,
enfermedad
main
cardiovascular
cause
en
of
el Perú
death by
y en el mundo.
cardiovascular disease
Muchos
in Peru and
pacientes
in
no
the world.
alcanzan
Many
el tratamiento
patients
óptimo
do
por
not
demora en la
have an
asistencia
optimum
al centro
treatment because of
hospitalario,
delay in the
demora en el
assistance in the
transporte,
hospital centers,
falta de
delays in the
celeridad una vez que se
transportation, lack
logró
of
llegar a una
celerity
emergencia,
once they got
retraso en
into
la
the
toma de
ER, delay
decisiones,
in the
falta de
decision-making
equipos de
process, lack
equipamiento
of
oportuno. Todas estas cosas se
equipment.
pueden
All these
mejorar.
things can be improved.
Todo esto se puede
All of
mejorar.
this can be improved.
Existen pocas salas de
There are
hemodiálisis en
very
Lima y peor
few
aún en provincias.
hemodynamic
Sé que
rooms in
ahorita hay
Lima and
hemodinámica
even worse
en
in provinces. I
Chiclayo,
know that they have
en
one in Chiclayo at
Cajamarca
this
sé que
point, in
también hay
Cajamarca. I know that they have
hemodinámica,
a
en Huancayo,
hemodynamic unit in Huancayo as well,
en Arequipa,
in Arequipa,
en Trujillo,
in
en
Trujillo,
Ica. Y las demás
in
provincias
Ica, and the other
también deberían
provinces,
tener
they should also
para
have
tener un
one
tratamiento
to be
ideal
able
y
to provide an ideal
es
and
ideal
on-time treatment. It is
implementar unidades de
ideal
dolor
to
torácico a nivel
implement
nacional, pero unidades de dolor torácico
chest pain units
conectadas con la
countrywide, but
tecnología que
chest
hay hoy
pain
día y que
units
menos tienen
connected with the
celular.
technology that we
Hasta
have nowadays, a cell phone.
quizás el portero del hospital tiene un
Everybody
celular
has
donde
a
puede
cell phone.
poner
Even
una
the
fotito de
doorman of the
desinfusarlo
hospital can
a un
has an
dispositivo.
um,
Debemos estar
phone.
conectados, todos los
Take
médicos
photos
con
of the
nuestros colegas
ECGs
de
and send
otros
it to
lugares.
another person. We
Tener
need to be
equipo médico, al
connected. We
menos un
need to have medical
electrocardiógrafo y un
equipment,
cardiodesfibrilador,
at least a
y
ECG
educar al
machine
personal.
and
El
cardiodesfibrillator,
personal
and
debe
educate
estar
the staff. The
entrenado,
staff should
todo
be
el
trained,
personal en
all the staff
RCP básica y avanzada.
in basic and
Es
advanced
importante entender que el
cardiovascular
tiempo es
reanimation. It's
vida, no
important to learn that
solamente
time is
nosotros los
life, not
médicos,
only
las
us, not only
enfermeras,
for us, for physicians,
todo el
nurses,
personal del hospital,
all the
hasta los
staff of the personnel,
pacientes.
and even the
Hay que actuar en
patients. We
relación a
need to
ello y por
act
eso educar a
related
la
in
población
relation
para
to that,
acudir
and
a
we therefore
especialidades de
need to
evaluación
educate
médica, para
population
diagnóstico y
to
tratamiento en
go
caso
to
de tener
medical
un
care
dolor
immediately
torácico
to
agudo.
get
Puede ser que no
immediate
sea la
diagnosis
lesión
if they have a
cardíaca,
chest
puede
pain. It
ser que no
might
sea
not
un
be
infarto, pero si lo
an
es,
infarct or a heart problem,
estaremos
but if it
preparados
is,
para
we will
poder
be ready to be
salvar una
able to
vida.
save a
Son
life.
necesarias más salas de
We
hemodinámica
need more
sí,
hemodynamic
cardiólogos
rooms or units
intervencionistas.
and
Acuérdense que
interventionist
si no está la
cardiologists. Let's
hemodinámica
remember that
bien,
if
si no hay un
a good
cardiólogo intervencionista,
in
no
an
se puede salvar.
hemodynamic unit, if there is
Entonces hay
no
que
cardiologist,
facilitar hoy por hoy
no
la
use.
formación
So
de
we need to
médicos
facilitate
cardiólogos
nowadays
intervencionistas debe ser
the
potenciada.
cardiologists, interventionists that should
¿Y
be
por qué no
potentiated.
decirlo?
And why
Mejorar
not
las
to say it? We
alternativas de
need to
transporte
improve
de pacientes para minimizar
the
el
alternatives
tiempo de
to transport
atención.
patients to
Es
minimize the
difícil, pero no
time
es
to
imposible.
care.
¿Por
It's
qué no
difficult, but
disponer
not
de un
impossible.
helicóptero
Why
para
not to have
lugares
a
cercanos para
helicopter, maybe
trasladar a los
for
pacientes?
places
¿Por
that are
qué
not that
no,
close
pues, un
to transfer
avión que aunque
patients?
sea
Why
en
not an
6 horas
airplane? Maybe
llega a
that
un
in
paciente? Y
2 hours they can bring a patient.
saber
And to know
que los fármacos
that
necesarios
drugs, the
para brindar
necessary
una atención
drugs to
oportuna y
provide
primordial a un
timely
paciente
critical
con
care for
enfermedad
a
coronaria
patient
aguda
with
deben
an
estar
acute coronary
disponibles,
disease
pero no solo
has
disponibles,
to
sino que
be
se
available,
sepan
but not only
utilizar.
available, but they need to know how to use
También los
them.
podemos
We
monitorear
can
por
also
vía
monitor
telefónica,
this by phone,
por una
by
comunicación por Zoom, etcétera. Pero es
Zoom,
importante la
etc.
educación
But it is
del médico
important to have the
internista
education of the physician
que
or
va
the
a proveer ese
interns that
tengan todas
go
las
to provinces,
posibilidades de poder
they
cumplir
should have all
con
the possibilities
esta,
to be able to
este
provide
trabajo
this
tan importante.
type of care that is so important to reduce cardiovascular disease.
Muchísimas gracias.
Thank you
Hay
very
una
much.
cascada de decisiones que
This is a
tomar.
cascade because there is a cascade of
Claro.
decisions to be made as
Muchas
well to be
gracias.
successful. Thank you very much.
Muchísimas gracias, estimada
Thank you very
doctora
much,
Chávez,
dear
por
Dr.
su
Chavez,
interesante
for your
y
very
amplia
interesting
disertación. Realmente yo creo
presentation.
que
I really
ese
believe that
lema del cual hablaba la
this is the
doctora Malky,
motto that Dr.
¿no?
Malky
Es
was
el hecho
talking
de
about,
exponer
this
y ya
motto.
incluso
That's what
tenemos
you
que
have
actuar.
promoted. We need to act.
Actuar para
We need
cuidar
to act to
justamente los
actually
corazones de nuestros
take care of the
pacientes,
hearts
¿no?
of our patients,
Usted
right?
en su
You,
disertación
in
ha sido
your
muy
presentation, you have been
clara
very, very
en
clear
reafirmar
in
que
reaffirming
este primer
that
nivel de
these
atención, donde
first level of cares
generalmente
were
es la puerta de
generally
entrada de
that's
la
the
mayoría de
door of entrance
pacientes, ¿no?
for most
que
of the
quieren ser atendidos
patients
sobre
that
todo en zonas
need to be taken care of,
alejadas de
especially
nuestro
in
país,
areas that
¿no? En
are
realidad
remote in our
no es
country.
todo Lima y
The
Lima
reality is that
inclusive
not everything
el
is
primer
Lima, and even in
nivel de
Lima, even
atención es la puerta
inside
de
Lima, the
entrada
first
para
level of
la
care is the
mayoría
entry
de
door
problemas de
or
salud o
entry gate for
emergencias,
most of the
y esto
health
está
problems or
muy ligado
emergencies.
a lo
That should be
que
very much linked
continúa en el
to
manejo, ¿no? A lo
what
que
follows
sigue
in the
después,
management,
¿no?
to
No
what
puede haber
follows. So
un
you have said there
nivel de
cannot be
atención
a first
aislado.
level of care that it's
No puede haber
isolated.
un
There
primer
cannot
nivel
be
de
a first
atención
level of care
donde haya un buen
where
nivel
there is
o
a
un buen
good
sistema de
level, a good
referencia, en
reference
donde
or good
nosotros
referral
podamos
system in which we
realmente
can
continuar
really
esa
continue
atención de
with
la
that
persona con una
care
cardiopatía
of
isquémica
the
y
person with
que
an ischemic
esté pues
cardiopathy, and that is
realmente bien
really
implementado
well
para que pueda
implemented
salvar esa vida, ¿no?
to be able to save that
Alarmante las
life.
cifras que usted nos ha dicho de
Very
que de
alarming
cada
the
7
figures that
varones,
you have shown
uno
that out of
fallece por
7 men,
enfermedad
one
coronaria
dies
y
out
de
of a
6 mujeres,
coronary disease,
una
and
fallece
6
también por esta
women,
enfermedad. Cifras
one
muy altas,
dies
¿no?
of this disease as well. Very high figures. And
Sabemos
well,
pues que esta
we
enfermedad
know
es la causa
that
más
this
común de
disease is the
muerte,
most
¿no? Por
common cause
enfermedad
of death
cardiovascular.
due to
Realmente
cardiovascular
esto
disease.
sigue en aumento,
This
en
really
incremento por
continues increasing
los
mm,
problemas, los factores
because
de
of the
riesgo que usted
problems or
muy
the
bien
risk
nos ha
problems,
detallado, ¿no? La
factors that you have
hipertensión que está en
detailed very well, the
aumento, la
hypertension, that it's
obesidad, ¿no? Que es
increase in
una de
obesity,
las
which is
pandemias en
one
este
of the
momento
pandemics that we
en la
have
mayoría de los
nowadays in
países,
most of the
¿no? Estamos
countries.
con cifras muy altas
We
de
have very
obesidad
high figures
desde
of
la niñez,
obesity
inclusive
from
la
childhood even.
diabetes, que es otro
Diabetes,
problema
which
que
is another
también muy
problem,
serio, ¿no?
very
El
serious one
tabaquismo,
actually,
el
smoking,
estrés, ¿no? Por
stress,
la calidad de vida y los cambios
uh,
en las
because
conductas
of the changes in
actualmente,
life and the changes in the
todo ello
behaviors
pues está
nowadays, all of
originando un
that then
incremento
is
de esta enfermedad,
resulting in an
¿no?
increase of
Entonces,
this disease. So
usted muy claramente nos ha
you
explicado
very clearly have
todas las
explained to
posibilidades,
us
pero yo
all the
quisiera también
possibilities, but I would
recalcar
also
el
like to
tiempo.
highlight
Usted nos ha
time.
dicho que el
You
tiempo es
have
vida.
told
Yo
us
creo
that
que eso
time
es
is
algo muy
life. I think
importante que
that
debe
that is
quedar en
something
nuestros
very important that should
profesionales y en todas las
remain
personas que
in our
escuchan,
professionals
porque hay
and
pues
everybody
siempre
listening to
muchos
us, because
retrasos
there
en
are many
todo nivel,
delays
¿no? Y
always at
tenemos
all
que evitar
levels. And we
justamente
have
eso,
to
¿no?
prevent
Hay
that
que
actually.
evitar
We need to
los retrasos
prevent
desde el
delays
diagnóstico,
from the
desde el
diagnosis,
manejo,
from
desde que se
management,
recibe en el
from
primer
the
nivel
moment that we
hasta que se
receive in the
refiera,
first level
si
until the
este
patient
primer
is
nivel de
referred.
atención
If this
no
first
puede
level
ser
of care
capaz de
cannot
darle un
be
primer
capable of providing
auxilio o un primer
first
manejo,
aid
pero
or
quiero también
management.
resaltar que todo personal de salud debe estar bien capacitado en hacer
All the
algo
health staff
tan
should be very,
sencillo
very well
como es la
trained in doing
respiración,
something that it's
¿no?
as simple
Sabemos
as
que
an
muchos de estos pacientes
cardiovascular
llegan
reanimation, because we know
inclusive
that
a
many
tener
of
un
these
paro
patients
cardíaco, ¿no?
even
Entonces
get
hay que
to
minimizar,
have
siempre pensar
um,
en minimizar
heart
el tiempo de
arrest. So
atención
we
al
need to
paciente
minimize, always
necesitado un
thinking in
pulmón,
minimizing the
un
time
dolor
for the care of the
torácico que
patient.
llegan
You
a
have
las
mentioned this very
emergencias,
well
¿no?
with
Y
patients with chest pain
importante la
getting to the
creación de
ERs, and
massificar más
important
esta
the
creación de estas unidades
massify the creation of
neurológicas, ¿no?
these
Lo que
chest
permitiría
pain
evitar justamente
units,
esos
which
retrasos
will
al
allow
tratamiento
to
adecuado. Si
prevent
se
these delays
sospecha
in the
más aún
adequate
de un
treatment if
infarto
we
agudo
have
al
any suspicion of an
estimada
myocardial acute
doctora
infarct.
Chávez, ha sido
Dr.
una
Chavez, it's been a
presentación realmente muy
really
interesante,
very
la cual
interesting
agradecemos, ¿no?
presentation. We thank
Felicitamos.
for that.
Ya
We
nos están
congratulate.
llegando
We are
muchas
receiving
preguntas,
many
¿no?
questions, actually,
Comentarios,
comments,
y
and
estas preguntas serán
these
resueltas al
questions will
final.
be
Vamos a
answered at the
invitarlos
end. So we will
a
invite
quedar en
you
espera en la sala
to continue with
para
us.
al final poder resolver esas preguntas. Muy amable.
Muchísimas gracias. Estaré atenta.
Gracias, doctora. Seguidamente, para abordar el tema hipertensión
So
resistente
then,
y
now to
falta
talk
de
about
adherencia al
systemic
tratamiento,
hypertension lack
Le
of
damos la más
adherence to the
cordial
treatment, we would
bienvenida
like to
al
kindly
doctor Pedro
welcome
Martín
Dr.
Salazar
Pedro Martín
Cáceres,
Salazar
quien es
Cáceres,
médico
who
especialista en
is a
cardiología,
specialist in
presidente de
cardiology,
la Sociedad Peruana de Hipertensión
chairman of
Arterial
the Peruvian
y
Society
profesor
of
asociado
Arterial
de la
Hypertension,
Universidad Peruana de Cayetano
associate
Heredia. Sus
professor of
estudios
medicine
de
in
pregrado
Cayetano
y
Heredia
especialidad,
University, where he got his
miembro
degree,
titular de la
and
Sociedad
specialty
Peruana de
the member, full member
Cardiología,
of the
fellow de la Sociedad
Cardiology
Europea de
Peruvian Association,
Cardiología,
member of the
cardiólogo
uh,
asociado de la
European Society of
Clínica
Cardiology, and
Ricardo Palma.
associated cardiologist of
Adelante, doctor
Ricardo Palma
Salazar, es suyo el espacio.
Hospital. Dr. Salazar, you have the floor.
Muchas gracias por la invitación, gracias por las
Thank you very much for the
palabras de
invitation. Thank you very
presentación,
much for this
agradecer al organismo
introduction
andino por
words.
invitarme en
Thank you
esta
to the
reunión
Andean
y
organization for
gracias a la
inviting
doctora
this
Carmen
meeting, and
Calle, que
thanks
es la
to Dr. Carmen Calle as
que
well,
ha convocado
who
básicamente a
has
estas reuniones y con la que tenemos una estrecha
convened
relación para el
convened me to
manejo
this
de
meeting, and with
los
whom I
problemas
work very closely in
cardiovasculares, en
terms of the
especial la
management of
hipertensión.
cardiovascular problems, particularly
Veamos,
hypertension. Very well
pásame la
then.
siguiente diapositiva.
Let's go to the next slide, please, if you are so
Bien,
kind.
la medición
Very
de la
well.
presión arterial comenzó
The BP
de manera
measurement
más o
started
menos simple con un
in a
método de
simple manner with
1905.
a method
En
since 1905. In
1895, Rivarocci
1995,
desarrolló su
Rivarocci
tensiómetro que vemos en azul
developed
en la
its
parte alta,
tensiometer, which
con
we
una
see in
evolución,
the
pequeños
top part
cambios, se
with the
modificó el equipo y
changes.
que permitió
This
atrás
equipment was
algunos
modified, and
años
this is the
como
equipment
el
that we've been
método
using
más
until some few
fidedigno de
years
obtener la
ago
presión
as the
arterial.
most accurate
10
method
años
to
después,
obtain
un
BP.
militar ruso
10 years
distinguido
later, a
Korokov
Russian
utilizó un
military
estetoscopio y lo puso
Kodakov
debajo
used a
en la
stethoscope
arteria,
and put it
debajo
under
del
the artery,
costado del manguito,
the
y logró determinar
side
que
of
cuando
the
se medía la presión con el
sleeve, and
manguito,
he determined that when they were
podía
measuring the pressure with
tener
this,
unos ruidos, que los
they
ruidos
could
se
have
volvieron famosos,
some
que lo llamamos ruidos de
noises,
Korokov,
the
y que
Korokov
se clasifican del
noises,
1 al
very
5,
famous, and that
el
are
1 para
classified from 1
obtener
to
la
5.
presión
1
arterial
to have
sistólica y el
the
5 para
systolic
obtener la presión
BP, and
arterial
the 5
diastólica,
to
y es la
have the
forma como hemos
diastolic BP.
aprendido a
And
medir la
that's the
presión
way in
arterial
which we have
todos
learned to
nosotros, todos
measure
los que hemos estudiado
BP. All of
medicina,
us,
todos
all
los
of
que hemos
us who have
estudiado
studied medicine, all of us
enfermería o
who have studied nursing
ciencias de la salud.
or
La
health
siguiente.
sciences. Next.
Sin embargo,
However,
vemos
we
evolutivamente que
can
los
see
conceptos en
the evolution
hipertensión,
of the concepts in
según ahí en la línea
hypertension.
del
We can
tiempo, en
see that, as you see
1905,
in the timeline in
se desarrollaron o se
1905, there were
publicó los ruidos de Korokov y de ahí se
the
comenzó a
Korokov
medir la
noises
presión
were
arterial.
published, and then they
Años
started
previos hubo
measuring
muchos
the
intentos de desarrollar
in the
equipos para
previous
medir
years,
la
there were
presión
many
arterial,
attempts to
pero
develop
recién
the
en
equipment to measure
1905
the BP, but
pudimos tener
only in
un valor
1905
de presión arterial
we could have a value of BP,
y teníamos un valor con el cual no
and
sabíamos
we
qué
had
hacer.
a value that we
Desde
didn't know what to do with
1905
it.
hasta
Since 1905
1960,
to
el concepto de
1960,
presión
the
arterial
concept of
se
blood
medía,
pressure
había
was
valores,
measured, there
pero no
were
teníamos
values,
claro qué
but
hacer con ellos.
we were not
Durante
clear on
60
what to
años,
do with them for 6
el
years.
concepto en esa época
The
era de que la
concept at that
presión
time
la
was that the
elevación de la
BP, the
presión arterial,
elevation of
era
the
un mecanismo
BP was
fisiológico del
a
cuerpo
physiological
para
mechanism
mantener
of the
la
body
adecuada
to
perfusión
maintain
de
an
los órganos.
adequate
Por lo tanto,
perfusion of organs.
no era necesario
Therefore,
bajarlo,
it was
incluso
not
podría ser
necessary to reduce it, and
contraproducente para
even
la
it
presión
might
arterial.
have even been
Recién, con
contraproducing
la línea de
to
tiempo, vemos
decrease
en
the BP.
1948
And as you can
un
see,
estudio de
only in
Framingham
1968, they started
que
with the
fue
Framingham
motivado un poco o
study, which
impulsado
was
también
kind
por
of
la muerte del
motivated or
presidente
promoted
Roosevelt, que
by the
murió de
death of
una
the Russian
hemorragia
president that died of
intracerebral
an
debido a una presión arterial
intra-brain
extremadamente alta. O sea, a
hemorrhage.
partir de 1960 aparecen
And
los
from
primeros resultados
1960,
del
we
estudio
started
Framingham y, oh
looking at the
sorpresa,
first
nos
results of
dimos
a
cuenta
Framingham
que la
study,
presión
and
alta hacía daño.
surprise, we realized that the
Y
high
también otro
BP is
punto
damage,
muy
it causes
importante, en
damages. And
1966
then in
aparece el primer
1967, there is
estudio
another
clínico
important point, the
que
first
dice
clinical
que si le
trial,
damos un
which
medicamento a
indicated that
alguien que
if
está
we
con la
give
presión
a
alta,
drug or a medication to someone with high
se
BP,
reduce la posibilidad de que esta persona tenga
they
un
reduce
evento
the
cardiovascular,
possibility
un
that this
infarto,
person has a
un
cardiovascular
ACV,
event, an
sea
infarct,
insuficiencia cardíaca, lo que
or
sea, un edema agudo pulmonar.
heart
En ese estudio de
uh, insufficiency or
1967, los
whatever. With
criterios
the
de
study in
inclusión para
1967, the
pacientes que hoy
inclusion
día lo
criteria
consideramos
were
en cuidados
patients that we
intensivos, el
now
criterio de
will put
ingreso es
in
tener una presión arterial
intensive
diastólica
care.
entre 115 y
Uh,
130. Ese valor de presión hoy día
BP is
no
15,
pensaríamos que podría
115,
entrar en un estudio
130.
comparado con
Those
hipertensión.
values
Pero en ese
nowadays
tiempo
wouldn't
ese estudio
be
marcó un hito
applicable,
porque a
of
partir
course,
de
but at
ahí
that time this was a
comenzamos a
milestone
buscar
study, because from
un
there we started
valor
looking
de
for
presión
a
arterial al cual
value
tenemos que
of
llevar a nuestros
BP
pacientes.
that we had to
La
take our
siguiente.
patients to. Next.
Y vemos que durante el tiempo
We
han
can see
aparecido
that
muchos
throughout the
estudios y
time
ese
there have
estudio
been many
que
studies
da,
there, either
tenemos
endless studies, really. We have hundreds of papers talking about the treatment of high BP, multiple studies that have tried to determine what is the value of the BP that we should take our patients to, what is the time in which we need to give the medication to our patients, if there is a medicine that can be better than another one, or it might be a combination that might be better than the other one. We have tried to respond to this, and after 60 years that we've been treating BP, we still have many doubts in terms of what is the BP target. We have many things here, but we still have some doubts regarding some things that are in controversy still. Next. Based on this, there have been many drugs. We can see those that are in white boxes, diuretic, like spironolactone, clistherin, diuretics like thiazidalide, furosemide. We have medications of central action, clonidine, dopa, no. Then CC blockers, the dihydropyridines, and others like ditilizem and verapamil, the RAS blockers, and beta blockers, and those that have alpha and beta effects. These are the drugs. Unfortunately, for us, most of them have already fulfilled their cycle of research, and therefore they are already sold as generic products. And we have a great variety of drugs that we have available at a price that we could say is affordable for most of the patients, or that are available in the health systems to be able to treat our patients. In the bottom part, there is a group of drugs that are still under research that are trying to enter as inhibitors of the corticoid inhibitors, or others that are in phase 2, that in phase 3, which are parenteral type of medication to block the synthesis, which might be for patients that do not want to take medication. So we have many studies, many drugs. We have 60 years of research looking at how we can treat patients with concomitant diseases like diabetes, patients that have suffered heart arrest, maybe, or an infarct, or patients with a cerebrovascular accident. And what are the results of these 60 years of research on multiple drugs to treat BP? Next, we can see that if we go to the bottom right chart, hypertension control, you can see, and this is a study published in 2013, based on the data that of the peer study, we can see that the control rate in the different groups, you can see men compared to women, urban area versus rural area, high economic income and low economic income countries. None of them, the control rate of hypertension in none of them gets to even 20%. Women are a little bit better, they have a little better control than in men. There is a little better control in urban areas compared to rural, and better control in the high income countries compared to the low income countries. And in the low income countries, you can see that patients with a higher level of education, they have a clear, better control than those that have a low level of education, something that doesn't look so different in the high income countries. But certain here is that in their control rate for high BP, a disease that we have had for 120 years, that we learned after 120 years that we have learned how to measure BP, we see that we are only controlling less than 20% of the population that suffers of this disease. Next. And this is something a little bit closer. This is Latin American countries. This is from 2019. This is control again. In each one of the groups, we have the control in the right. In the group of age, we see that the patients over 50 have a better control than those younger than 50. In terms of sex, there is a very clear difference. Women have a much better high BP control than men. There is a better control in the urban area, although the difference is very short, and a better control if you have a better level of education. But in none of the groups, there is a control that has a very high percentage. In average, they are around 22, 20%, and that happens all over Latin America and probably in the whole world, with a little better control, maybe a slight better control in women that have this disease. Next. What are the consequences that we can see from this poor control? I mean, when we have the percentage of patients with a high BP, there is a group of patients, since this is an asymptomatic disease, there are some people that don't know that they have high BP and they do not seek for care. There is a group of patients that know that they have high BP, but for different reasons, side effects, they are not convinced of the treatment, do not take drugs. There is a large group that take the medicines or the drugs, but they are not controlled. And that group, that control group that doesn't get to 20% is the group that it's controlled. What are the consequences of a bad or a poor high BP control in a group of people that do not take the medicines or do not know about the disease? You can see in the upper bar, deaths attributed to these high risk factors. High BP is the cause number one. How many patients die in a year as a consequence, directly or indirectly, of high BP? Almost 10 million people. Not all of them die directly out of pressure, some because of high hypertension that generates kidney failure. Some others have a stroke because of hypertension. Some others have coronary disease or heart disease, but directly or indirectly, around 10 million people die annually because of consequences of the high BP, high blood pressure. This has a higher mortality than COVID in the 3 years of pandemic. There are no 10 million people that have died. This disease doesn't cause the fear, the panic that COVID caused, that everybody was in lockdown, but it has a mortality that is higher than that of COVID at its worst. What happens in Peru? In Peru, we have this concept of detecting what is the prevalence of high blood pressure. This is a survey ended done by the National Institute of Statistics. Then survey in 2022. We do it every year. This is from 2022. We go to households. They contribute 36,650 households. They ask people if they had hypertension, and they also took the BP measurements with this on-room equipment that you see here. What is the result? The prevalence of high blood pressure in Peru is 22.1%. When we compare this with other countries, someone might say, but Peru has a lower percentage because it's 22%. Well, in reality, INEI has done this with people of 15 years of age or more, by including people from 15 to 18 that do not have other things. They put a very large group of people with very low prevalence, and that makes the number of prevalence to go down. In reality, if we were only doing this in people of 18 or more, like the Society of Cardiology, the prevalence might increase to 25, 26%, which is probably a real number. These are not different numbers. It's simply that we are taking different groups of population. The prevalence in male is higher, almost 25% in male and 20% in women. And this is what we got in ENDES, in the survey of 2023, which is statistics from 2023. Next. What does this mean? What does this mean in absolute numbers? Well, that in Peru, if we consider that people over 15 years of age are 25 million in Peru, when 1.2% of prevalence, there should be 5,600,000 people suffering from this disease, of which most of them are not controlled. Many people, they do not know that they have hypertension. And if we separate this by age group, those above 60, which represent 4 million, around 4 million, in that population of more than 60, INEI says that 53% of the patients of that age group are hypertensive, which means that people over 60 years, there are 2.2 million people having hypertension. That's almost half. Most of the hypertensive people are elderly people. And although I do not like to mention that group, I'm already an elderly person, but I do not have hypertension, fortunately. Here, we can see what happens with the age in this group, both men to the left as women in the right. You can see that based on the age group, we can see how the prevalence of high BP increases. The first bar is the normotensive, the second pre-hypertension, and the to
Si
its
vemos
hypertension. If we
caso de
see
los varones,
in the case
el
of
grupo de
male,
60 a
in the
79
groups
años,
from
vamos a ver
60
que
to 69 years of
la
age, we can
prevalencia de
see that the
hipertensión es
prevalence of
alrededor del
hypertension is around
65%.
65%.
Y en mayores de 80 años,
And
la
in
prevalencia
older
es
than 80, the
69%
prevalence
en
is
el caso de los varones.
69% in the case of
Vemos a las
male.
mujeres, vean
And
que
let's
para
go
los
to
mayores de
women. You can
80
see that
años,
for
la
female
prevalencia de
older than 80, the
hipertensión
prevalence of
está
hypertension
alrededor de 75, 76%.
is around, well, it's
Mayores de 80
76%.
años,
In women older
las
than
mujeres
80,
tienen una mayor
women
prevalencia
have
de
a higher
hipertensión que
prevalence
los
of
varones.
hypertension
Entonces,
than
estos son
men.
números reales.
These
¿Qué es
are
lo que pasa
real
con
numbers.
nuestra población?
And
Hay un
what
análisis
happens with our
importante. Vean la
population?
siguiente
There is an
diapositiva, por
important
favor.
analysis. Let's go to the next slide.
Estas son las características de
These
la
are
población
the
peruana que deben ser muy
characteristics of the
parecidas a
Peruvian
la
population that
población
might be
en
very similar
Latinoamérica.
to the
En
population
el
in
año
other countries
2000
of Latin
hay
America. In
26
2000,
millones de
there
personas
were
en Perú
26 million people
y
in
en el
Peru,
año 2024,
and in
este año,
2024, this
estadística
year,
actualizada, son 34
current
millones de personas.
statistics is 34
¿Qué
million
significa que
people.
la población ha
What
crecido
that
en
this means that the
28%?
population has
Pero si
grown
vemos el grupo
28%.
etario
But if we
de
see the age
0 y
group
14
between
años,
0 and
en el
14
2000
years of
había
age,
9
in
millones de
2000 there were
personas
9 million
en ese
people
grupo etario,
in
mientras que
this
en el
age group,
2024
while
hay
in
8
2024
millones. A
there are
pesar que la
8
población
million, despite the
se ha
fact the
incrementado en
population has
28%,
increased in
las personas
28%,
jóvenes se
young
han
people
reducido
have the
de
number of
10
young
millones
people
a
has
8,
reduced
casi
from
un
9 million
10%.
to 8, almost
Y
in
vean abajo en la
10%.
parte
And you
inferior,
can see at the
mayores de
bottom of the
60 años.
screen, people
En el
older
año
than
2000
60.
había
In 2000
1.900.000
there
personas
were
mayores de 60
1.9
años.
million
Y en el
people
año
over
2024 hay
60, and in 2024 there are
4.747.000. Es
4.7
decir, que la
million,
población se ha
which means that
duplicado
the
más del doble.
number of
Y si miran
population,
el
the
círculo en
population
verde en la
has
parte de
doubled.
abajo,
And if
los
you can see
mayores
the
de
green
80 años,
circles, people
tenemos
over 80,
190.000
we have
que se han convertido en
190,000 that have
740.000. Este es el grupo etario
converted
que ha
into
crecido
740,000. This is the
proporcionalmente
age group
de
that has
manera
grown
más
proportionally
importante. Y como
in the
acabamos de ver
most
en la
important
diapositiva
manner. And
anterior,
as we
son
have
el
seen in
grupo
the
que
previous
padece
slide, this is
con
the group
mayor
that
prevalencia de
suffers with
hipertensión.
more
Cerca
prevalence
del
of hypertension. Around
75-80% de estas
75,
personas,
80%
este
of
grupo
these
etario,
people in
son
this age
hipertensos. Por
group are
tanto, nuestro
hypertensive,
problema con la
or
hipertensión no
our
va a
problem with
disminuir, vamos a seguir
hypertension is
viendo
not going
cada
to
vez
decrease.
más
We will
hipertensos,
continue looking
van
at
a
more
haber
and more
una prevalencia
hypertensive
mayor
patients.
porque la
There's going to be
población
a
envejece
higher
y por lo
prevalence
tanto va a haber
because the
más
population ages,
hipertensos. Es un problema
and
que nos
therefore there
toca
will
a
be more
todos porque
hypertensive
realmente
people. And this is a problem that affects us
es
all,
seguro que todo el
because
mundo tiene
it
algún
is
pariente o sufre
for
de
sure
hipertensión o
everybody
tiene un
has a
pariente que
relative or
padece de
suffers from
hipertensión. Es un
high
problema
BP, or a
que afecta
relative
a
that
gran
suffers high
proporción de
BP,
la
and this
población
is
peruana.
a
La
problem
siguiente.
that affects a large proportion of the Peruvian population. Next.
Yendo al tema ya de hipertensión
Now getting
resistente, que
into
podría ser
resistant
una de las causas
hypertension, that
que
might
las
be one of the
personas no
causes
tengan una
for
presión
which
controlada.
people
Vamos a ver que al final
do not
la
have
causa es
controlled
bastante
hypertension, and we
pequeña
will
y es
see
el
that this
ojo.
is a
La
very
hipertensión
small
resistente se
cause.
define como una
Resistant
presión
hypertension is
arterial
defined as a
que está
BP
por encima de
that
los
it's
valores meta
persistently
recomendados.
elevated
Los
above
valores
the
meta
target
es
values
diferente a la
recommended,
Sociedad
I think
Europea
target
y
value,
a la
because
Sociedad
the
Americana, que está
European and
tomando
American
3
have different
medicaciones
values, and that are
hipertensivas que
taking three
incluyen un
antihypertensive
bloqueante del
medications,
canal de
which
calcio,
include a
un
calcium channel
bloqueador del
blocker,
sistema
a
renina-angiotensina, o sea, un
block,
PRIT o
renin
losartán,
angiotensin
y un diurético, todos
blocker,
los
renin
medicamentos a la
laproxasan,
dosis
and a
máxima
diuretic,
o la
the
dosis
medications at the
máxima
top
tolerada por el
dose, or
paciente
the
y en la
maximum dose
concentración
tolerated by the patient,
apropiada. Si tienen
and
captopril,
with
alguien
the
toma
adequate
captopril, por decir,
posology.
no
If
puede tomar
someone
una
takes
pastilla de captopril
captopril, they
para
cannot
diabetes,
take one
no es
captopril once a
apropiado.
day. That is not
Si
an
voy a tomar
appropriate
captopril, tendría
regime.
que tomarlo
If
3 veces
they
al día
take
para que
captopril, they
tenga
need
un
to take it
efecto
3 times a day
farmacológico
for
que
it to
cubra las
have
24
the
horas. Entonces,
adequate
tienen que ser
pharmacological effect that
3
covers the
grupos
24 hours. So
terapéuticos
it needs to
a
be
la
three
dosis más
therapeutic
alta que
groups
tolere
at
o a
the
la dosis
top
máxima del
doses they
medicamento
tolerate, or the
y
top
que
dose of the
a
medication,
pesar de esa
and
terapia
that
se
despite
encuentre
this
en valores
therapy,
por
they
encima
still have
del
values
rango
above the
definido. En el caso de los
defined
americanos, la siguiente
range. In the case
diapositiva,
of
en
the
el caso de los
Americans, next
americanos,
slide.
ese valor sería de
For
130 con
Americans,
80.
this
Si es
value would
más de
be 30,
130 con 80
130
y
with 80. If it's
está
more
en
than
esa proporción de
130 with
tratamiento,
80, and you have
hablaríamos de
that
una
type of
hipertensión
treatment, we would be talking
resistente.
about a
Finalmente
resistant
recalco que debe
hypertension.
ser a la dosis
Again,
máxima
I
en
highlight
3
that it
grupos
should be the
terapéuticos
top dose in the
diferentes.
3 different
Y para
therapeutical
hablar de
groups.
hipertensión
And to talk
resistente
about
tenemos que
resistant
definir que este
hypertension, we
paciente
need
no
to
sea
define that
una
this patient should not be
pseudohipertensión
a
resistente.
pseudo
Tenemos que descartar que
resistant
tenga un
hypertension. We
efecto de
have
bata
to rule
blanca
out that
y
it
tenemos
doesn't
que
have a
descartar
white
un
coat
problema tremendamente
effect, and we
serio
need
que es
to rule out a very serious problem, which is the lack of adherence to treatment. Very important. Many people do not take their medications at the adequate dose. Sometimes they do not take any medicine, actually. And it happens here because some people that come, but your pressure is very high, but sorry, I haven't been taking my pills because I didn't have it for the last 2 months, but I feel okay. And to talk about hypertension, resistant hypertension, we speak, no, not yet. To talk about resistant hypertension, you need to have these three conditions. For the Americans, more than 130 with 80 in this treatment, or for the Europeans, 140 with 90 for defining resistant hypertension, and to have the scheme of treatment with 3 drugs at the top dose and having an appropriate diuretic based on the kidney function, like thiazide. The thiazide, if the kidney function is in 30, probably it won't have any effect. That patient needs to be changed to a thiazide-like diuretic or another one. Click. So once we have defined and we believe that the patient is resistant, we have to define that the patient doesn't have a pseudo resistance to hypertension. And here we need to confirm adherence and exclude this condition that it's called white coat hypertension or the white coat effect. We're talking about hypertensive. White coat hypertensive is those that are not hypertensive but are out of the medical office. No, what they have is a white coat effect. The patient has the high blood pressure despite taking their medication when they go to the physician, but they have normal pressure when they're are outside the medical office. Once we have defined the pseudo resistance cause, we need to look for secondary hypertension forms, primary hyperaldosteronism, parenchymal kidney disease, obstructive apnea, renal artery stenosis, cardiac Cushing syndrome, coarctation of our aorta, another endocrine causes like patients with hyperthyroidism or parathyroidal disorders. We need to exclude secondary forms. After we have these secondary forms, next one, we can define that the patient might have, we can define the commitment to know whether this patient is really resistant, and then we need to have a recommended algorithm that we will apply. Next. It is important to bear in mind the of the white coat hypertension, because we see when we measure the pressure in the office and outside the office, we will have this problem that in some cases, the patient is hypertensive in the office, but not it's not hypertensive when he's outside. That's what we call white coat hypertension or white coat effect. And there's another group that has hypertension when they are in the office. They have the BP close to the normal range, but when we measure outside the office, it's elevated, and that's masked hypertension. And these two groups that in which the pressure doesn't match the office and outside might represent up to 40% of the patients. Therefore, nowadays, all the guidelines for the management of hypertension nowadays recommend, apart from measuring the pressure in the office, measuring it outside the office with a outpatient monitoring or a measurement at home, with, of course, a standard to do so. Next one. The other problem is inadequate measurement of the BP. When you measure the BP, well, you have 3 variables to take into account. One, the patient needs to be adequately prepared, a person that is crossing the legs, a person that talks while we measure the BP, or a patient that wants to go to the toilet with a distended bladder, they will have higher values. If we do not have adequate equipment, we will also have an error in the measurement. And if the person that measures the BP is not trained either, there's going to be an error in the quantification of the BP. So we have 3 aspects, and this is also a cause for a lack of control. It might seem that the patient is controlled if we measure the pressure well, or the other way around. We might diagnose that someone has a bad control, when in reality, if we have followed all the steps, the right steps to measure BP, the pressure would have been controlled. Next. That's why the European Society and in general, all the guidelines give recommendations. We are not going to dwell into detail, but there are some characteristics of what do we need to do to measure the BP in the right manner. The current recommendation suggests to use equipment, panaeroics, not the mercury-based equipment that in theory is the best method to measure the BP because of the mercury, which is very toxic. The fabrication is discontinued, and there is a recommendation for them to disappear, and they recommend the use of oscillometric equipment, which is the digital measurement of the BP. Unfortunately, in our country, we only they only sell equipment for houses, not for hospitals that are equipment that are sounder. Pieces of equipment that unfortunately have a very high cost. But there are a series of guidelines that, well, I would need another presentation to present all the guidelines. But the incorrect measurement will lead us to errors in the definition whether the patient is controlled. Next, please. Well, we can have this piece of equipment is similar to the mercury one, but it's digital as well. Next. And what we recommend when you don't have a oscillometric piece of equipment, we recommend right equipment, but they need to have a calibration done at least every month. Check that the needle is really marking 0 and that there are no leakages in the system, which is the right manner of measuring BP. Next. The other problem, which is pretty serious in patients for which there is no control, are patients that don't take their medications. As physicians, check the patient. We have read all the theory on how to prescribe a medication, know the function, and we select the most adequate treatment for the patient, and then we write a prescription. But the medication do not work if someone this is very important to have an adequate control. And we define adherence when the person takes at least 80% of the recommended scheme, and it is the behavior that a person has in the case of medication. If they are going to adhere to the medication, this is a process that it's well analyzed and very complex. There are people that have problems at the beginning. They do not buy their medication. The physician explains, tells them, okay, you have to take this medication because it's convenient for your health. The person doesn't buy it. And you can see that according to the US registers, 12% of the patients with hypertension do not start the treatment, even though they have been prescribed medication. And for the first year of the diagnosis, 30 to 80% of the patients are not adherent. Many abandon the treatment, and that depends extensively on the health system and the evaluation method and how the relationship of the physician and the patient to recommend the medication. Even in research studies, when a patient accepts to participate and signs an informed consent, there are 4 to 5 patients, 5% of the patients that say that they will take a medication from a research protocol and they do not take it. And in practice, in real life, this might get to 20% of people that say, well, this medication is adequate for your health, it's convenient for you, and do not start the pharmacological treatment. Next one. You can see that this is adherence that has been quantified, and you can see that in the age group 50 and 70, those are the ones with a better adherence. You can see that this graph refers to non-adherence. Non-adherence, there is a 20% here that doesn't adhere to the medication, is 50 to 70 years. The younger have less adherence, and the older has less adherence for different reasons. Patients have memory problems, the elderly people take multiple drugs, one for the pressure, another one for cholesterol, antiplatelet, arthritis, and many medications that have symptoms, and sometimes they feel to not solve any symptom, and they tend to just not take the medication any longer because they believe that it's not making any effect or it's not protecting them. And if they take medication, they decide to stop the hypertensive pills. We that treat patients, we realize very frequently that we write a prescription to the patient and the patient says, no, give me that pills, doctor, because I still have a lot of these pills. But why do you have so many? We have given this, and you should have to get rid of those. You have taken them all. No, I'm not taking them. And this is everyday situation in patients with hypertension and many other chronic diseases, as we will see later on. Next one. Evaluate adherence is a very complex process. We can do surveys and ask patients if they take medicine, even electronic sensors. When you want to see, we have patients with hypertension that is resistant, and we say, well, this patient, maybe this is because he's resistant. or what? There are many methods then to evaluate the adherence to treatment. Methods that are simple, like a questionnaire, but we have little reliability. Methods that are digital with sensors that record when the patient opens the bottle. Well, the patient can open the bottle and not take the pill. That might be the case as well. And counting of the pills in the pharmacy, that's a very efficient method. Most of the insurances can register when the patient pick up the medication and when they come back to pick up medicine again, and that can be an accurate manner to say whether they are taking or not the medication. And the most complicated theory is the biochemical detection measure in the blood if the patient has the adequate serum level based on their dosing. In high complexity centers, when they have resistant patients, up to 40% of the patients that are identified as resistant, the cause is that they do not adhere to the medication as they should. And as I heard sometime Dr. Williams said in the UK, in some cases, patients that have been identified as resistant do not take any of the medications that have been given to them. Next. Next, one more, please. So the strategy to identify when to suspect that a patient is not adherent when we give two medication to reduce the BP and the BP is reduced in tens than 10 milligrams of mercury. Patient with apparently resistant BP, patient that we take out a beta blocker and comes with a BP above 75, for a patient that was in treatment, okay, everything right, and then suddenly starts having a bad control of the BP. These are reasons to suspect that the patient is not adhering to treatment. When you have a good relationship between the patient and the physician, and you ask and tell him to define what they are doing, in many cases you can identify that it is a patient that has decided not to take a medication, and sometimes you need to discuss, sometimes simplifying the number of the pills. Maybe many pills or tablets. In some cases, patients do not recognize, and then you have to count the pills or measure in serum, the blood in blood to see whether the patients are adherent to the treatment. Next one. And this is a referral center in which they have sent patients with resistant BP, high BP, and we can see that the causes is non-adherence to the medication in 40%, white lab effect 40%, inadequate measurement of BP 30%, and treatment under the one indicated. And this part is part of the physician, of course. That's what we call therapeutical inertia. Inertia, the patient comes to the office with a high BP, but the patient says, I'm okay, don't give me more pills, and the physician decides to leave the patient with this high BP, even though without giving anything, based on the suggestion of the patient that he's doing okay, and maybe he thinks that it's a white coat patient, or the patient has, no, the patient is fine with this concept. No, coat effect, no, in my home, I'm okay. That's why in these patients, especially, we need to use the measurement outside of the map of the office with a mapping or domicile measure. Next one. So the adherence is a very serious problem. We need to take the very much problem of adherence, especially when there's polypharmacy in the patient, especially in the first year of treatment. Many people do not start adherence. Adherence is lower in very young people or very old people, and especially in patients with a low socioeconomic condition. The drivers are multiple and might coincide in one person, an elderly person with side effects of the medicine that has difficulty to mobilize and to go and pick up the pills, who's might coincide or be there in one single person. So I believe that to strengthen the relationship between the physician and the patient and identify which are the reasons for which the patient is not adhering, that's one of the best strategies. A relatively low-cost strategy without, but you need time for that. You need to sit, and many times in the hospitals we have very short times. In private hospitals, they tell you you have 20 minutes for this patient, otherwise you are not working okay. This is not strategic for the institution, right? Next, so once we have determined that the patient is really hypertensive, and we have ruled out that this patient has either resistant hypertension or that has a
puede dar un clic, por favor, a la
Click,
siguiente.
please, in the next one.
Hay que
So
intensificar lo que
we need to
corresponde a los
intensify
estilos de
what
vida en
is
este
the
paciente que
lifestyle
ya
in
es
this patient, which
definidamente
is
resistente. Hay que
definitively
funcionarlo bien,
resistant. We
hay
need
que
to
la dieta baja
make
de
sure
sal,
that
mucha
they eat
gente
well,
consume
low
una
salt
dieta baja de sal, come reflujo,
diet.
baja sal a
Many
los
people do not do
alimentos,
this, even they put
consumen
more
muchas
salt in
cosas
their
que
food,
contienen
or they
grasas
consume many
orgánicas
things
como
that
productos
have high content
engrosados
of
o
salt,
productos
like
procesados.
packaged products or
Hay que
processed products.
incentivar la
Uh,
pérdida de peso
we
y
need to
el ejercicio
incentivize the weight loss
ayuda
and
a un mejor
exercise, which
control de la
also
presión
helps to a
arterial.
better control of high
La
BP.
siguiente.
Next one.
Entonces, una vez que hemos
So
recomendado
once
esto,
we have
tenemos que asegurarnos que
recommended
el
this,
paciente
to make sure
nuevamente
that the
esté
patient
cumpliendo con la
again
medicación
will be
que
adhering
se
to
le ha
the
recomendado
medication
como
that
es la
has been
triple
recommended,
bloqueante del sistema de
uh,
angiotensina, bloqueante
the
del beta-2
three
dismutasa
drugs,
y un
the
diurético asociado a la
diuretic, the
función renal.
calcium channel blockers,
Repito,
and the
antiácidas no
angiotensin
funciona cuando
system
la función
blockers.
renal está por
The
debajo de
thiazides that do not work.
45
Remember, when
decibelios de
the
efecto y
renal
por
function
debajo
is
de
under
30 de
45
depuración,
its
las
effect, and under
tiazidas
30
no
of
tienen.
clearance, the
Ahí se puede
thiazides do
usar
not have an
tiazida
effect.
light.
There you
La
can use a
siguiente.
thiazide light. Next
Podemos
one. We can
también descartar la hipertensión
also rule out
secundarias y entonces ya lo que
the
tenemos
secondary
después de
hypertension. So after all these
primera línea
first
de
line
manejo
of
con un paciente que
management
realmente
with
es
a patient that
hipertenso
is
resistente,
really resistant or
y
hypertensive.
aquí el
Next,
primer paso
here the
constituye el
first step
cambiar
will
el
be
diurético
to change
tiazídico por
its
un tiazida
acidic
light, y ahí los recomendados
diuretics,
son el uso de clortalidona,
thiazide
puede ser
light,
usado hasta
even
una
cortalidone
depuración
that can be
incluso menor de
to a
30, cerca
clearance
de
under
20 de
30,
depuración,
close to
o la
20 in
verapamina, que
clearance,
también es
or
un diurético,
hydrapamid,
que es un
which is also a
medicamento que tiene
diuretic,
efecto de
which is
calcio
a
antagonista y
medication
un
that has
efecto
a
diurético
calcium
que
antagonist
tiene un
effect and
mejor
a
efecto
diuretic
que el
effect that has a better
hidroxiapatida.
effect than the
Si en ese paso
hydrochlorothiazide.
no responde,
If
el siguiente
in
paso,
the patient doesn't respond, the next step will be
una diapositiva siguiente, a ver,
next.
denle un clic.
One click more,
El
please.
paso 3 ya es agregar un
Step 3 would be to
antagonista de los
add
receptores mineralocorticoides, de
there are
preferencia la
corticoids
espironolactona.
receptors
Sin
antagonists,
embargo, la espironolactona, todos los varones tienen muchos
spironolactone,
efectos secundarios,
but it has
ginecomastia,
many side
en
effects,
mujeres tiene
especially male
alteraciones en la
gynecomastia, in
lubricación
women
menstrual, el ciclo menstrual,
alterations of the
y
menstrual
el
cycle,
eplerenone es un
and
medicamento similar, pero con
plerennone,
mucho menos
it's
efecto, casi
similar,
ningún
but with
efecto
less or
del
almost
área de la
no
esfera
side effect
sexual.
in
Por lo
the
tanto, es una
sexual
alternativa, pero se
side
requieren
of
dosis más altas.
things, and it's an
Requieren una
alternative,
base entre
and they need
25 y máximo
higher
50
doses.
mientras que
The
el
eplerenone
entre
needs
dosis entre
doses
50
of
hasta
50 to
100
100 milligrams per day. It's
Al
very
siguiente,
high
el
doses.
siguiente
Next
paso ya
one.
son pasos
It's
que van
are steps that
no
will
tanto de un protocolo,
not
de
that
una
much
manera
of a
demostrada con una
protocol
línea de
or
evidencia, sino un poco más
way
de
that has
opinión
been
de expertos,
demonstrated by
entonces
evidence, but
sí
this is
vale
the
la
opinion
siguiente
of experts,
y
individual
podría
decisions. Next
ser
one,
un poco la
and that
decisión del
might
médico y
be
experiencia.
the
Aquí ya se
decision based on the
se
decision of the
recomienda
physician and
referir
the
al
experience.
paciente a
Here,
centros de
we
atención
recommend referring the
especializados en
patient
el manejo
to
de
a
hipertensión.
specialized
Pero si la frecuencia cardíaca
healthcare
está por
center
debajo o
specialized
por
in the
encima de
management of
70,
BP. But if
se
the
puede adicionar un beta bloqueador, puede ser un beta bloqueador de tipo metoprolol,
heart
bisoprolol,
pressure is
o
under
en
40, you
muchas
can
drogas
add a
efecto
beta
alfa beta
blocker,
como la betalol o
metoprolol
la
or
primidol.
bisoprolol, or alpha beta
Si el
blocker
paciente
like
tiene una frecuencia cardíaca
labetalol,
baja,
carvedilol.
podríamos usar
If
un
the
beta bloqueador
heart
y ahí se
frequency is
puede referir al
lower,
agonista
we
del sistema
cannot use
central,
a
como
beta
puede ser
blocker, but they would recommend an
clonidina, como puede ser
central agonist alpha,
levodopa, como puede ser flutoxacina,
clonidines,
no tanto la tamsulosina,
guafisocina,
pero sí la doxazoxina que tiene un efecto
and
mucho más rápido
doxazocine
del
that
día. Se
has a
podría
more
incluso
sustained
agregar
effect
si
throughout the
ese
day,
calcio
or they
antagonista
could
que requiere el
also
paciente
add
es un
calcium
bloqueante
antagonist if it
lepidopyridínico,
is
se podría agregar un
dilopyridinic
diltiazem siempre y
antagonist.
cuando la
They
frecuencia
could
cardíaca no
use
esté muy
the
lenta. La
diltiazem if the
siguiente
heart frequency is not too high, of
ya son
course.
casos
Next.
con
Well, these
bastante
are cases that
frecuentes.
are
La
very
hydralazina no
infrequent
hay
to
disponible en
add
nuestro medio, es un
hydralazine. We do not
medicamento
have it
que
available
pobremente se
in our
tolera.
country.
La
This is a very
siguiente,
poorly
el siguiente
tolerated
paso es usar
medication,
el
and the next step
minoxidil,
will
que
be to use
también es un
minoxidil,
medicamento de pobre
which
tolerancia
is a very
y son ya
poorly
para centros muy
tolerated
especializados
medication, and these
para
are for very
considerar la
specialized
otra
centers,
opción que ya es
and
la
to consider the
rehabilitación,
other
que ya
option,
sería
which is
una
the
alternativa al tratamiento. La siguiente,
renal replacement, which is another option in the treatment.
la guía europea
The
publicada el año
European
pasado
guide published
recomienda
last year recommends,
su
well,
estadística dice que
the
aparentemente
statistics
la
indicate
hipertensión
that
resistente es un
apparently the
10 a
resistant
20%.
hypertension is
Sin
10 to
embargo, después se
20%.
confirma
However,
que es
that
una
after they
hipertensión
confirm that
verdaderamente
it is
resistente,
a really
la
resistant
verdadera hipertensión
hypertension,
resistente
the
es
real
alrededor del 5%.
resistant
Quiere
hypertension
decir
is
que
around
uno
5%,
de
which
cada
means
20
that
personas
one
que
out
están
of every
diagnosticadas de
20
hipertensión
persons that
podría
are
tener una
diagnosed with
hipertensión resistente.
hypertension might have
Y ahí
resistant
recomienda
hypertension.
intensificación
And they recommend identification of the lifestyle and consider referring the patient to specialized centers for the management of type of hypertension. They also recommend if the kidney function is above 130, blocker central action, CCV, and if it's under 30, replace the thiazide for chlorthalidone or a loop diuretic, which they could also use a beta blocker or a centrally acting agent. But this is for management in specialized centers, of course. Even worse, the last consideration, which is denervation, renal denervation in patients that are in this condition. They have gone through the fourth drug and they still have very high BP. They have a clearance above 40. Might be an alternative for very specialized centers in Peru. There have been very renal denervation with good results, but very few. It's not a process that it's routinely used. Next one. Always bear in mind when we find a patient that do not have a control the pressure, that is not receiving other medications. There are a series of substances, drug-like substances and some others not, that can increase high BP, anti-contraceptives, non-steroids, anti-inflammatory drugs, and others that block the renin-angiotensin system, that do not allow these medicines to work in the BP. Increases even paracetamol, but only if it is in very high doses, it might have an effect in increasing the high BP, or corticoids, anti-cancerous drugs as well, that also develop hypertension, antidepressants like venlafaxine, are very frequently stimulants for an increase in the BP. So we need to take into account the medication that the patient is receiving. And next one. Well, the European guide has a very similar definition, but this is a guide that was published 1 week ago in the Congress of the European Society of Cardiology. The definition is the same. They just do not consider when they have 4 drugs and they are controlled as a resistant hypertension. And they, very important, they have the classification of the pseudo-resistance. And you can see that here they highlight as a cause of pseudo-resistant poor adherence to treatment, white coat phenomenon, poor BP measurement, that is in an inadequate measurement of the BP, and another more phenomenon like marked bronchial artery calcification, clinical inertia as well, very important phenomena. The physician that decides not to increase the dose because the patient is receiving maybe medicines or they do not want, and the Munchausen syndrome, someone that wants to be sick and simulates the disease. And to finish, this is the recommendation of the guide published 1 week ago, very similar. Rule out, the treatment is the same scheme, rule out pseudo-resistance once the patient is defined as being resistant, and they rule out secondary forms of BP. They recommend spironolactone and aledadenone, if the drug, if the heart frequency allows a beta blocker, and then there are different options after that, which are kind of a personal opinion, or using alpha blocker, centrally acting, or considering the renal denervation, and that's for people with preserved renal function. And the last one, finally, resistant hypertension represents 8 to 21% of the population with hypertension, but there is a very high percentage that are pseudo-resistant as well. The really resistant are around 5% according to the definition of the European Society. The lack of adherence to treatment and the white coat effect represent almost 50% of the apparently resistant cases. The antagonist of the mineralocorticoids receptors like spironolactone and eplerenone are the fourth medication. We could use as a fifth or fourth medication the beta blockers if we cannot use this medication due to the decreased renal function, and highlight always that the spironolactone has many side effects, particularly male, and that the dose of plerenoid is higher than the spironolactone dose for getting an equivalent effect. But we highlight hypertension. We still have a lot to learn. We have not yet defined exactly where are the limits of where do we need to get or up to where we need to get. There are controversies among the guidelines. There's many people not controlled yet with these definitions that could be even improved more. But this is due to problems of non-identification of the right measurement of the pressure, not to identify patients with white coat phenomenon. Not the adherence to treatment is a hugely serious problem that we need to investigate, and we need to evaluate in all of our patients that are not controlled with BP. And this is therefore a phenomenon that is suffered by the population, not only Peruvian population, but American population and worldwide population. That's the end. Thank you very much, and we will be here for your questions if there is any.
Doctor Salazar, muchas gracias
Thank
por
you,
su
Dr.
amplia
Salazar,
e
for your
interesante disertación, ¿no?
presentation.
Realmente hemos
We
escuchado
have
desde la
really heard
historia de cómo se
progress
han hecho,
for you,
se
how
ha ido logrando los avances que ahora tenemos, ¿no?
progress
Los
made,
múltiples
the
estudios,
multiple
medicamentos, todos esos
trial
años de
studies,
investigación,
education, all these years of the
todo lo que
research,
tenemos publicado, sí,
everything
usted lo
that
ha
we have
resaltado que
published, and you have
después de
highlighted
120
that
años,
after
¿no?
100
de todos estos
years of
estudios,
all these
solo
studies,
controlamos a
we
menos
are
del
only
20% de
controlling
las personas.
less
Un
than
tema
20% of
sumamente
people,
grave
something
porque
that is
sabemos las
very serious
consecuencias que
because
de
we
ello
know
se
of the
derivan. Y
consequences
esto se da no
that
solamente en nuestro
stem from
país,
this, and
sino a
this
nivel de
happens not
toda
only in our
Latinoamérica y el
country, but
mundo, ¿no?
also in Latin America and the world.
Una enfermedad, como usted también lo ha dicho,
All these
y
things
lo
that you
hemos
have
escuchado
said,
siempre,
and as we
silente,
have heard,
muchas
always
veces no causa el
silent.
temor, no causa
Many
el
times
pánico
it
que nos
doesn't
causa el COVID,
cause
sin
fear, not
embargo,
didn't cause the
mata mucho
panic that
más,
COVID
mata mucho
caused,
más
but
año a año,
kills many
¿no?
more people, year
El
after
tema también
year.
de cómo
The
nuestra población pues,
thing
ha
is how in
virado
our
definitivamente
population has
en las últimas décadas. Ya no
changed in
tenemos
the last few
una
decades.
pirámide
Do not have any
proporcional
longer
con base
a
ancha. Tenemos cada vez
population
menos
pyramid
niños,
that it's
menos jóvenes
wide base. We
y
have
cada
less
vez
and
más
less
adultos mayores,
children and
lo
less
cual
young people and
crea un
more
mayor
elderly people with it's
problema, porque
also a
efectivamente
more
vamos a
difficult problem
tener,
because we
ya
will have,
tenemos
well, we
ahora una
already
mayor
have
prevalencia de
nowadays
esta
a higher
condición,
prevalence
ya
of
que
hypertension
usted también lo ha
because,
manifestado en los de
as
mayores de
you have
80
very well
años,
said, in
pues estamos
people
cerca del 75 al
over 80 years, we
80%,
are around
cifras
75,
alarmantes de una
80%,
población
very
que sufre de hipertensión
alarming figures
arterial,
of
que le habla
population
sufre de
that
hipertensión
suffers
arterial,
high BP.
madre
Myself,
que
I
sufre de
suffer high
hipertensión
BP. I'm
arterial,
a
así
mother
que
suffering from
sé de lo que
a high
hablamos.
BP.
Y
I know
bueno,
what we're talking
el
about
tema de la
then.
hipertensión resistente es
And
todo
resistant
un
hypertension,
reto realmente,
this
¿no?
whole challenge
Si
really.
bien nos ha dicho usted, un 8 al
If
21%, ¿no?
even you
Se
have
tiene
even you
control de
have
la
told us 8 to
hipertensión,
21% do not have
pero hay
control
que
of
descartar
hypertension,
esos
but need
pseudoresistentes, ¿no? Un
to
gran
rule
problema el
out or
tema
those
de la
resistant a very
adherencia al
serious problem
tratamiento,
of
¿no?
adherence to
Cómo
treatment.
tenemos que
How do
investigar,
we need
lograr
to
captar
do
que
research,
ese
try to
paciente tenga y cumpla con su tratamiento,
understand
¿no?
if this patient
Y
has
es
a
tan
treatment or is
importante
compliant with
entonces, por lo
treatment? And
tanto,
it's
que
so
ese paciente
important then that this
cumpla con
patient
ese esquema. Entonces, a veces,
follows
¿qué
or adheres
sucede?
to
Que en
him.
nuestro
Sometimes what
sistema de
happens
salud,
then is
¿no?
that in our
Los
health
tiempos en la
time,
consulta no
in
permiten a
the
veces lograr
we do not
esa
allow
adherencia,
sometimes to
no
achieve this
permiten lograr
experience. It
esa
does not
educación
allow
al
to
paciente
achieve
y
this
muchas veces
education to
esas
the
pueden ser
patient,
las
and many
causas
times
del
this
fracaso del
might be a cause
tratamiento, ¿no?
for a failure of treatment.
Estimado doctor, muy amable,
Dear doctor,
muy
thank you very
interesante y
much. Very
completa su
interesting and
presentación.
very
Yo creo
complete,
que
thorough presentation.
realmente por
I
ello tenemos
believe
muchas
that
preguntas que en
that's
breve
why
vamos
we
a
have many
realizar.
questions that we
Le
will
pedimos
be
mantenerse en
asking
sala y en
soon.
breves
We
instantes vamos
request
a
you to
iniciar
remain
todo
here in
este
the room
diálogo a
because in a
partir de
few
las
minutes we will
preguntas de
start this
nuestros
dialogue from the
participantes.
questions of our
Queremos,
participants.
antes de iniciar ello,
Before we start
agradecer a
that,
todas
we
las personas que están
thank all the
conectadas de los
people that are
ministerios de
connected from
salud,
the
de
ministries
la
of health,
academia, de
from the
diversas
academia, from
entidades y
different
organizaciones
entities
sociales
and social
de
organizations
muchos países, ¿no?
from
Dentro de
many
ellos está
countries,
Argentina,
among them
tenemos
Argentina,
Chile, Cuba,
Chile,
Ecuador,
Cuba, Ecuador,
Honduras, México,
Honduras,
Venezuela,
Mexico,
Perú y
Venezuela,
entre
Peru,
otros, ¿no?
obviously, among
Hemos
others.
recibido muchos saludos y
We have
felicitaciones.
received many
Para
greetings
iniciar este
and
diálogo a
congratulations.
partir de
Start
las
this
preguntas
dialogue from
formuladas,
the
pido
questions
a nuestro nuestros dos
I would
ponentes, por favor,
ask
encender
our two
sus
speakers to
cámaras
please turn on your
y vamos a
cameras,
iniciar este diálogo a
and we
partir de
will
las
start this
inquietudes
dialogue
que nos han
from
hecho llegar.
the questions
Trataremos
that
de
we
dar
have received. We will
respuesta a
try
la
to
mayoría
answer
de ellas.
most of them.
Bien. Pregunta para el doctor Martín Salazar.
Questions for
Nuestra
Dr.
región
Martin
cuenta con
Salazar.
la
Our region
tecnología
has
adecuada para el
adequate
diagnóstico de la
technology for the
hipertensión
diagnosis
arterial
of
resistente.
resistant high blood pressure.
Si tenemos una respuesta simple, podríamos
If
decir
we
que
want a
no, en
simple
el
question, we
sentido de
could
que no
say
hay
no,
implementación de
in the
equipos
sense
de
that there
mapa,
is
por
no
ejemplo,
implementation of
en primer nivel de atención. Hay limitaciones en cuanto a la
equipment
posibilidad
in
de
the
la
first
interpretación, pero ahí los
level of
CAMS
care. There are
no tienen
difficulties
el
or in
correcto
terms of the
equipo para medir la
interpretation. They do
presión
not have
arterial. Los
sometimes the
equipos
right equipment to
recomendados hoy en
measure
día son los
the
equipos
BP. The recommended equipment
oscilométricos,
nowadays are the
son para uso en
oscillometric, but
domicilio.
those that are
Los
for
equipos de
home
domicilio
use.
son para
The
medir la
home
presión a
use
una
equipment are
persona,
to
a dos
measure
personas, en una
BP to one
casa, pero
person or two
en un
people in
hospital
one
el
home. But
equipo
in a
tiene que medir la
hospital,
presión
the
arterial
equipment is to
a 100
measure
personas
the
en un
BP of
día
100
y por
people
lo
in
tanto
one
los
day,
equipos de casa
and
no se pueden
therefore
ubicar en poco
the
tiempo.
home
Entonces se
equipment
requieren
will
equipos de uso
get
hospitalario.
broke
Lamentablemente, por
down
ejemplo, en
in
el Perú,
till time, and
los
we need
equipos
hospital type of
hospitalarios,
equipment.
ninguna
And
de
at
las
least in
marcas
Peru, the
vende
hospital
equipos
equipment, none of the brands that
oscilométricos
measure this kind of
y
equipment
venden en el Perú los equipos
sell
de
in
uso
Peru
hospitalario.
equipment for hospital use.
Tenemos que recurrir a nuestro
We
sistema
need to
aneroide, que muchas
go
veces
back to our
yo, si
Android
trabajo en una
system that
clínica
sometimes
privada,
I
me
work in
encuentro
a
con que el equipo
private
aneroide
hospital and I
tampoco está
find
adecuadamente calibrado,
that this
ando
equipment that is
devolviendo
not
a cada
well
rato los equipos.
calibrated. I have to
Debe
turn
pasar
it
mucho
back all
peor
the
en los
time.
hospitales. Yo he trabajado
Things
27
might be
años en
worse in the
hospital
hospitals. I have
público
worked for
y
27
los
years in a
problemas eran
public
serios.
hospital and the problems were serious.
Tratábamos de
We
solucionarlos,
try to
pero
solve
hoy en
them,
día,
but
lejos de mejorar las
nowadays,
falencias que
instead
hay en
of
los hospitales, a veces no hay reactivos para pedir una
improving the
creatinina, un
things
hemograma, para
that
pedir
we
cosas
have in the hospital,
que
we do not have
consideramos
even reagents to
esenciales.
do creatinine or things
Entonces,
that are essential.
pedimos
So
tensiómetro de
ask a
calidad,
tensiometer of quality, good
de
quality
uso hospitalario.
for
A
hospital
veces puede
use.
pensar uno que es pedir
Sometimes
demasiado, pero no es.
one might
La
think that it's
respuesta es
too
no,
much.
no tenemos los
But the
equipos
answer is no. We
adecuados,
don't have
no se
adequate
dispone de
equipment. We
suficientes
don't have
equipos de mapa,
enough
pero la
map
medición
equipment,
correcta
but
y la
the
medición en
right
domicilio ayuda
measurement and
mucho.
the
Tenemos que incentivar a que
home
las personas
measurement
midan su
helps
presión en casa
extensively.
y
We need to
aprendan a tener un
incentivize
registro
people to
adecuado.
measure
No
their
solamente
BP at
póngase
home and having an adequate
póngaselo un ratito que
record.
verifique que
It's
es un
not
equipo que
just
está
buy the
certificado
equipment,
y empiece la
certify,
sesión.
check
No,
that it's
hay
certified
todo
and measure.
un
No,
esquema de
there is
medir
a
la
whole
presión
scheme to
durante una
measure
semana, de
pressure during
medianoche.
1 week, in morning
Hay
and
todo
evening.
un protocolo de cómo medirse
There
a
is a
domicilio
whole
para que ese
protocol on
día
how to measure
usted
this
que
in
vaya
the
a tener muy
home.
cercano al
So this
valor que
protocol
obtenía
is
en un
equivalent
hospital.
of those
Entonces, no, pero
obtained in
podemos
a
mejorar,
hospital.
es la respuesta.
No, but we can improve. That's the answer.
Muchas gracias, doctor Salazar.
Thank you very much,
Pregunta
Dr.
para la
Salazar.
doctora Edith
Question for
Chávez.
Dr. Edith
¿Qué
Chavez.
relevancia tiene el
What
diagnóstico y
relevance does
control de las
the
cardiopatías
diagnosis and
congénitas
control
en
of
los
congenital
primeros años de vida?
cardiopathy
¿Qué
has in the
recursos debe
first
tener
years
el
of life?
primer nivel de
What
atención para
resources
un
should the first level of
diagnóstico
care
precoz,
have
un
for an early
tratamiento
diagnosis
oportuno
and
y
timely treatment
rehabilitación?
and rehabilitation?
A ver, ahí hay varias preguntas. La
There
primera
are several
pregunta
questions in
sería
one. The first
en
question
relación a los niños con
regards
cardiopatías congénitas,
with
¿verdad?
congenital
Sí, los niños
heart
con
diseases.
cardiopatías
Yes, the
congénitas
children with
también pueden
congenital
tener
heart
enfermedad
diseases
coronaria, pero
also
por
have
lo general
coronary diseases,
se
but
debe no
generally
a arteriosclerosis,
are
sino a
not to
anomalías
atherosclerosis,
congénitas
but
de las
little
coronarias, es decir,
anomalies in the
coronarias que han
coronaries,
nacido
coronaries that have been
anormalmente
born abnormal
de otro
eh,
lugar. Las
in,
coronarias
in
son
a
arterias
different
que
place.
nacen de la
Coronaries
arteria
are
aorta,
arteries
las
that
primeras
stem from
ramas
the
de la arteria
aorta.
aorta.
They are the
Y
first branches of the
normalmente
aorta,
del
and
seno coronario
usually
derecha nace la
in
coronaria
the
derecha,
from
del
the
seno coronario
right
izquierdo nace la coronaria
coronary
izquierda.
vein,
A veces
we have the right coronary and
esta
left the same, the left coronary. So,
posición
this position,
anatómica normal de
anatomic
las
position,
coronarias se
the
altera de
normal
manera
anatomic
congénita
position of the
y eso
coronaries
puede
is altered
favorecer
congenitally,
que el
and that
niño
might
pueda tener
favor
una
uh,
predisposición
uh,
a
for the
una
child to have a
cardiopatía coronaria.
predisposition
Por
to
otro lado, en la
coronary heart
primera edad,
disease. On the other hand,
hasta
in
la
the
adolescencia, incluso con el COVID,
childhood,
ha
even
habido
in
a veces
adolescence, even
factores
with COVID, there have
protrombóticos por algunas
sometimes be
enfermedades
prothrombotic
virales
factors
que
from
pueden
some
causar
viral
también
diseases that
infartos
might also
agudos.
cause
También
acute
puede haber
infarcts.
desarrollo de
There might
aneurismas
also
y
be development
microaneurismas
of
en las arterias
aneurysm
coronares.
and
Esa es la
microaneurysms in the
patología
coronary
más frecuente
arteries.
en
That's the
niños.
most frequent
Felizmente es una
pathology in children.
patología bastante
Fortunately, it
rara
is a pathology that it's pretty
y creo
rare.
yo que en
And
el
I do
Hospital del
believe that
Niño
in
existen
the El
puestos
Niño Hospital hospital, the children's hospital, they have the professionals that are fully prepared to take care of them. Even in primary care, when we receive a child with chest pain, with a normal ECG, we need to refer them to the pediatrician. If the ECG is abnormal or in the exam we see any alteration, they need to be referred to a specialized center taking care of children, a pediatric hospital, or the pediatric service of our hospital. The second question was regarding rehabilitation. Yes, in Peru, especially in Lima, Arequipa, Chiclayo, I think, and Trujillo, we have cardiac rehabilitation units in the government, right? The hospital, I think, that has cardiac rehabilitation. Important, actually, is the part that comes after the arrest, after the angioplasty, after the surgery. In the Social Security and the military hospitals also have an adequate cardiac rehabilitation service and some private hospitals as well. And what they do there is first the patient needs to recover, the patient himself, guided by a professional. There is a specialty of cardiac rehabilitation and the patient needs to be guided by the rehabilitation person to do the exercise in a progressive manner so that they won't damage their health. Actually, they should have as an ally the exercise to recover the cardiovascular health. Of course, we don't have that in all hospitals of Peru, but that should be growing, that should grow. Is there anything of the question, any part of the question that I didn't answer?
No, está muy bien. Muchas gracias.
No, everything is okay.
Pregunta para el doctor Salazar.
Question for Dr. Salazar. What innovation, therapeutical innovation, have shown efficiency to reduce the polypharmacy and the high risk of abandonment in the treatment of high BP?
Bueno, las innovaciones o la mejor estrategia
Well, the innovations of the best strategy is to try to reduce the number of pills. I mean, use combinations, combined medications that can reduce the number of pills. People feel much better when they take a lower number of less pills. So if we can count the antihypertensive medications in one single drug or in the number of drugs with one medication, you can improve adherence a lot. The use of medications with a better profile that also allows, fortunately, most of the antihypertensive medications have a generic presentation. There is no any of recent appearance that indicate that this doesn't have an alternative or a generic presentation, and therefore that reduces cost. So one point of hypertension is cost. And costs have reduced a lot. No alternative for combination of drugs. That's the problem. The ideal thing, innovation would be that in some way they manufacture generics, but in a combination of drugs with which they will improve extensively adherence.
La adecuada combinación de medicamentos, o sea, hay medicamentos que su combinación
the other detail is that the combination sometimes is very good. That's why they recommend these three therapeutical groups. For example, they should not mix April with a sartan. That's an unrecommended presentation, a presentation that or combination that brought many problems more than benefits. At some point, they thought that it could improve the deterioration of the renal function, but it's not an adequate combination. Using beta blockers, first of all, well, there is a discussion. Beta blockers have been first considered bad, and they have came back in the European guidelines. They have been put in the first line if a patient has any indication like coronary disease, heart failure, tachycardia, etc. In that case, the beta blockers can become a first-line medication. So in conclusion to your answer, the best strategy is to try to use medications that reduce the number of pills, use presentations with a longer half-life, and the relationship physician-patient is very important. The truth is that the system obliges us to have very short consultations with the patient, and when you take more time with the patient, you ask why are you not taking the medicine? And the patient is honest and tells, well, because this medicine causes this or gives me this. Sometimes by changing the time or changing an alternative medication of the same family with less side effects, you might recover adherence. So I believe that the combination of pills and a good relationship between the physician and patient, creating a good history and hearing the patient what their concerns are. Because if you know a lot, I think that I know a lot, I've read all the guidelines and I say that this is the best pill and you have to take this pill or that other pill. And you need to put, and sometimes things do not work like that. So you have to, the person that we have in front of us, which is the patient, we need to convince them that this is beneficial for their health and that the scheme that they are receiving will bring benefits in the middle and long term with a lower likelihood. Many times people say, no, well, I will die. If I don't take the pill, I will die. And I say, no, you are going to die. You will have an ACV and you will be in your bed and you will need to use a diaper. You will have a tube in your nose. Do you want to be like that? No, 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 doctor, give me the pill. So there are arguments that you can use as well to improve adherence in patients that are difficult, especially. And then with the years, you learn who are difficult and how to deal with them. But that it's the relationship of the physician and the patient. Very important. Thank you, doctor. Very interesting. Question for Dr. Chavez. What recommendations would you give to professionals of the first level of care to reduce the gap of diagnosis of heart diseases between men and women? This is fundamental or critical. This is a very broad question. Starting from the fact that until little ago, fortunately now this has changed, but we used to give less importance to chest pain in women. Women came to the ER with chest pain and generally it was taken like, no, this is a 10, it's a stress problem, give her some diazepam and go home. Nowadays, medical education has strengthened the part of gender differences to take better care of everybody because women also have coronary heart diseases, and the older the age, the higher the probability, and the more and they can have the same incidence of meningitis. So I believe that in general, the health professional, whoever they are, the place they have is very important. All the patients, it's not only the physician, the patient that comes is the patient of this person that is there, is the patient of the person in admissions, of the person, of the secretary, the nurse, and the physician, of everybody. The patient is not only the physician's patient. So we should all be obliged to take care of them with respect, with a lot of dedication, and pay attention to their symptomatology, whether it is a man, whether it is a woman, whether if it is a child, a adult, or whatever. And we should take care of them in an adequate manner, focus on their symptoms, establish a diagnosis problem, and not to minimize anybody because she is a woman or he is young. There are young people, for example, have not talked about that, but there are patients that that are from drug dependents that have more probabilities that have an infarct. So to my recommendation to all healthcare professionals, if a patient comes to you for medical care, it is because they need help and we need to help them. We need to take them, we need to take care of them in an adequate manner. If they come with a chest pain, whether it's man, woman, elderly, young, or child, we need to give them the care they need. It might be that the pain is not important, but finally the physician will give the diagnosis and will take the responsibility of that and the treatment. So I believe that that is one first recommendation. And to the health professionals, I would like to recommend you to always train, to always be trained. Training helps us, give us tools to be able to help our patients. Training should be continuous. And these are the objectives of the Society of Cardiology and the Medical Association. That's why we have these programs of continuous medical training that we need to take advantage of. Thank you.
Bien, ya para terminar, agradeceríamos a cada uno de nuestros ponentes.
We would like to thank each one of our speakers to give us a brief message to all of our audience. Dr. Salazar, you have the floor. Final message. Well, to take into account what we have said, hypertension is the #1 risk factor for cardiovascular diseases, and we are doing very poorly in the control and diagnosis. And let me do my advertising. President of the Hypertension Society, and next week from the 26th to the 29th of September, we have the International Course of Hypertension, in which we will discuss diagnosis, how to measure pressure, conditions, women in pregnancy, in elderly people, conditions of different types. And it is a course that it's very complete and it's completely online. You might be in Tumbes, Puno, wherever you are. It can be any health professional, physician, non-physician that wants to register in the course. And we are giving a promotion for hospital physicians to give them a reduced cost. We can also have residents if there are some people that have registered from hospitals. That's a way to train. And as Dr. Edith said, we need to train. And these courses on hypertension are very important. And this course specifically will be recorded. It's on demand. The truth is that if you can see it at the moment, you will be able to see that 1 year later, if you have a doubt, and I didn't hear that, and I don't remember this, or I want to hear this again, that will be recorded for you to check it. So thank you very much.
Gracias a usted, doctor Salazar.
Thanks, Dr. Salazar.
Por su ponencia y todo lo que hoy
Thank
día
you
nos
for
ha
your
brindado.
presentation and
Adelante,
everything you have
doctora
given today. Dr. Chavez, your final words.
Well,
Well, I would like to make emphasis on prevention. Coronary heart disease is a disease that can be prevented. And how can you prevent it? Well, from childhood, we need to promote an adequate feeding, adequate nutrition without trans fats, lots of vegetables, lots of fruits. We need to increase the consumption of fish. We will see the country, a country with access to sea, we should consume more fish, promote exercise from childhood. Children need to learn how to walk and to practice a sport. Adults, in adults, prevent the consumption of tobacco and other substances. And adults that do not have coronary diseases that are young, prevent tobacco and or smoking and exercise. Prevention is, like a Chinese proverb says, it's better than cure to prevent. Please remember, from childhood, we should prevent the development of coronary heart disease. Likewise, Dr. Martin, thank you very much for having shared with us this scientific afternoon. Dr. Myra, thank you very much for your moderation, and thank you to the authorities of the Andean Health Organization for having invited me to participate in this beautiful event. Thank you very much.
Gracias a usted, doctora, por todos los conocimientos que hoy nos ha brindado.
Thank you, doctor, for all the knowledge. Thanks for the questions. We couldn't answer all of them, but we will take into advantage the questions for the next webinars. We value the participation and interest. Thank you very much for the excellent presentation to Dr. Edith Chavez, Dr. Salazar. Thank you to everybody, to all the participants, to the Orozconu team, to everybody that participated in this activity that was possible thanks to the commitment with Andean integration and Latin America.
La palabra a la doctora Marisela Malqui Osorio, secretaria adjunta del Organismo Andino de Salud Convenio Hipólito Unanue, para el cierre de este webinar. Adelante, doctora Malqui.
Gracias, Magda. Inicio dando y expresando nuestro agradecimiento al doctor Martín Salazar y a la doctora Edith Chávez por sus excelentes presentaciones detalladas, didácticas, sobre este tema tan importante que son las enfermedades cardiovasculares, ¿no? El Orozconu en esta ocasión, por indicación de nuestra secretaria ejecutiva, la doctora María del Carmen Calle Dávila, se puso este tema tan importantísimo, aprovechando el marco de la celebración de la salud del corazón, y haremos énfasis en ese lema que se está manejando para este año, usar el corazón para la acción, que debe ayudar a las personas a cuidar su corazón, a empoderarlas para instar a que se tomen medidas, mejores estrategias para su atención cuando sea necesario. Y quedarnos con lo que nos han dicho ambos colegas respecto a que lo mejor y lo más costo efectivo, como sabemos en salud, es la prevención. La prevención a través del curso de vida, desde la infancia, porque como decíamos al comienzo, para evitar tantas muertes, hablábamos de 20 millones, hay posibilidades de evitarlas, de prevenirlas, realizando realmente pequeños cambios en los estilos de vida, en mejorar los hábitos, mantener una alimentación saludable, nos han mencionado, bajar la sal, las grasas, y también procurando tener mayor actividad física y evitando el alcohol, el uso del alcohol, el consumo del alcohol y tabaco. Y algo que de repente hacemos poco o nunca o nada, empezar a tener el hábito, la costumbre de realizar los controles periódicos de la presión arterial. Nos han mencionado que apenas se diagnostica el 20% de los que padecen. Como es una enfermedad silenciosa, silente, y es el primer factor de riesgo para estas enfermedades cardiovasculares, realmente es algo que deberíamos empezar a realizar controlando la presión arterial mucho más frecuentemente, ¿no? Igualmente la glucosa y el perfil lipídico. También tratar de mejorar, disminuir el estrés, el sedentarismo con que realmente estamos en estos últimos tiempos, cada uno de las personas en los diferentes trabajos, lamentablemente. Las cosas, la tecnología ayuda, pero también nos ponen algunos riesgos que debemos manejarlos, aprender a manejarlos. Es importante recordar que cuando sucede un problema de un infarto de miocardio, nos ha dicho la doctora, el tiempo es vida, ¿no? El tiempo es valiosísimo para el diagnóstico, para el tratamiento, evitar todas las demoras desde el paciente y todo lo que sucede también en el sistema de salud. En ese sentido, creo que han sido muy detallados, de una manera muy didáctica, nos lo han repetido, nos han reiterado, tanto en lo que es el manejo del infarto de miocardio como en la hipertensión. La hipertensión que realmente nos ha preocupado y nos preocupa ver, y nos mostraba el doctor Martín Salazar las cifras, ¿no? Cómo ya se ha visto que las personas mayores de 60 años se está incrementando, son las que van a tener mayor problemas de hipertensión, mucho más las de 80 años. Entonces, creo que para evitar llegar con esos problemas a las edades que ya se está viendo en todas las poblaciones, no solo en nuestro Perú, la transición demográfica, estamos viendo que nuestra pirámide poblacional ya está cambiando. Entonces, también tenemos que cambiar todo nuestro cuidado integral a través del curso de vida. Nuevamente, reiterar el agradecimiento a cada uno de nuestros ponentes, a todos nuestros seguidores del webinar que semana a semana realizamos, que en esta ocasión ha sido el día martes, es un webinar especial y vamos a aprovechar para invitarlos al siguiente webinar, que es esta misma semana, el día jueves a las 11 de la mañana, que es cultivar una cultura de paz. En el marco de la conmemoración del Día Internacional de la Paz, también un tema muy importante, y los esperamos en esa fecha a todos, y reitero el agradecimiento a cada uno de ustedes, a todo el equipo de Loras, Magda, a ti y a todos y cada uno de los que han participado, y nos vemos el día jueves a las 11 de la mañana. Hasta entonces.
Vamos por el aire.
Gracias,
Ok,
gracias
muchas
a
gracias.
todos. ¿Ya?
Gracias, doctor. Salazar, gracias,
doctor Martín.
doctora Edith.
Gracias, Yadi, Milagros,
Muy bien,
Rob,
muy
todos,
interesante.
todos.
Feliz buenas noches para usted.
Tema importantísimo
Felicitaciones,
que,
excelente el
que
webinar.
preocupa y
Me encantó.
asusta.
Sí, claro, la manera en que lo han
Así
presentado,
es.
Dios mío.
Ojalá que
Sí,
sea muy motivador.
felicitaciones,
Ojalá
Magda,
que haya
muy bueno.
remecido,
Sí,
ojalá que haya remecido a nuestro personal de salud también, porque también va hacia ellos, ¿no?
Claro,
Bueno, va
súper
hacia todos, a la
importante,
comunidad,
súper
al personal de
súper
salud.
importante. Lo que ha señalado él en cuanto a los tiempos, a la
Así es.
atención, a prestar atención a los síntomas, signos. No, muy
Así
muy
es.
bonito.
Uy, sí.